Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 59 of Limb Lengthening Live, where the patients get to interview the guests. And today we're joined by the man who single-handedly transformed the industry that brings us all together. Some of you may know him as the Godfather of modern-day limb lengthening, and others as the King of limb lengthening. Regardless what you call him, he's the GOAT. So without further ado, please welcome back to the show, Dr. Dror Paley. Dr. Paley, welcome back.
Hey, Victor. Thank you so much.
Yeah. You are welcome. It's been forever since you've been on the show. We're so glad to have you back. And for good reason, because today we're going to do a very comprehensive overview of the complications of limb lengthening. So everyone, I'm just going to pull up my screen here. We're going to share a presentation that I put together for Dr. Paley. Okay. And I'm going to go full screen here.
Who is that handsome guy?
I wonder. It looks good, man. Look at that. Clean, modern. Oh, love it. All right, everyone. So today we're going to go over the limb lengthening complications with Dr. Dror Paley from the Paley Orthopedic Spine Institute in West Palm Beach, Florida. So without further ado, Dr. Paley, I'll just be your little slide guy, so you can just click next when we're ready to go. But so everybody knows the agenda for today, we're going to do a complications overview. So Dr. Paley's going to go through the most common or the complications of limb lengthening. And then there were patient cases that were submitted to me. So Dr. Paley's going to do an overview or a quick review of some of those cases. He's going to talk about how to pick a good surgeon. And then at the end, if we have time, we're going to open it up to live Q&A with Dr. Paley. All right, so here we go. So Dr. Paley, the first complication that everybody wants to know about is fat embolism.
Yeah, wow, that's the big one. That is not a common one, but it is the big one. So fat embolism, it occurs when chunks of fat, they're microscopic, but little bits of fat get into your bloodstream and they go into the veins go to the heart pumps the blood to the lungs to get oxygenated. But these bits of fat are bigger than the capillaries, the smallest blood vessels. So they plug them up. And when you plug up the lungs, blood doesn't flow through it and you don't get oxygenated. And in the worst case analysis, you die. Okay. And by the way, we have no way to stop it, fully prevent it, and absolutely no way to get rid of that fat in the lung. Your body has to do it themselves. So really scary. Now, why does it happen? And what's the connection to limb lengthening? So because we're now using implantable lengthening rods that go inside the bone, the hollow of the bone is not really hollow, it's full of marrow. And the marrow in adults, not so much in children, but in adults, has been replaced with fat. And so the inside of your long bones is no longer full of marrow, it's actually full of fat, okay? And this is from about age, probably 18 on. So it's only in young children is there, a lot of marrow in there. So when you push a rod inside of there, it's like pushing a plunger inside a syringe and everything gets pushed out the other end. Well, where can it go? So it gets pushed down through, by this plunger, which is the reamer. The reamer is kind of the drill bit that you push in, and it gets pushed down and the pressure increases and it gets pushed into the blood vessels of the bone and into the veins, and these go back to the heart and full of fat, full of little bits of fat. Now, how often does this happen? First of all, it happens in 100% of cases. Every single limb lengthening surgery with an implantable rod, you get some fat emboli going into the system. By the way, so you have a picture of a broken bone there. Most common way that femur fracture would be treated nowadays is to put a rod in the bone. We would ream the bone, put a rod in, and we'd shower the patient full of fat emboli, okay? Your body can tolerate, your lungs are kind of like a filter. They can filter out a certain amount of fat with no effect, okay? You wake up, you have no negative effect from that. Beyond a certain threshold, however, you get too much, and now you start having what's called fat embolism syndrome, FES. Now, fat embolism syndrome, that's why you might wonder, why don't we not put 4 rods in at one time? Because then you'd get a lot of fat emboli reaming 4 bones all at one time. It seems that the safe limit is 2 bones, but in some people, reaming 2 bones still causes fat embolism syndrome. What happens in fat embolism syndrome? What happens is you plug up so much of the lung circulation that your oxygen level drops. So we measure that using that thing on your finger, that with a red light. It's called a pulse oximeter. It was used all through COVID. You know, everybody had one of those things. So that measures the amount of oxygenation in your blood, and your oxygenation level drops. And if it drops below a certain level, okay, you need oxygen. So the simplest treatment, if we see a reduction in pulse ox, is we, have you breathe with those nasal prongs, the kind of tube that goes around your nose, and you're breathing oxygen. And then if the oxygen level goes up with that, no big deal. 2-3 days like that, and it goes away. Okay. It may increase your number of days in hospital, which is one of the reasons this stuff's not done as an outpatient, it's done as an inpatient. Okay. So that we can monitor this and make sure you're not getting into trouble.
Okay.
So think about other cosmetic procedures. You don't need oxygen, and you don't need to measure their pulse ox after, having a facelift or having a breast augmentation or whatever. That's why this, being a cosmetic procedure, has risks that you don't see in any other cosmetic procedures. Now, the second thing is, what if the nasal prong oxygen is not enough? Then we go to mask oxygen, where you're actually not only, so with nasal prong, you breathe in oxygen and you breathe out without the oxygen thing. So we get a mask, you're breathing in and out the oxygen. So it's actually a higher concentration of oxygen can be delivered. What if that's not enough and you're still short of breath? That's when you end up going to the ICU and getting intubated. So a tube goes down into your breathing tube, into your trachea, and the machine breathes for you. Okay. What happens if that's not enough? If that's not enough, you better hope that the institution you're at has ECMO. Okay, extracorporeal membrane oxygenation. And what that is basically a artificial lung. The blood from your body, we basically put you on bypass. The blood from your body goes out of the body into this machine, comes back into the body, oxygenated. The machine oxygenates you because your lungs are now so plugged, they're not working. No matter how much blood goes through them, they're not picking up enough oxygen. So ECMO is the last thing before you die. Okay, I'm not being melodramatic. So let me tell you about my experience. And my experience is the largest in the world with these implantable lengthening nails for stature or for non-stature, like leg length difference. So to date, we have a paper prepared that we're going to publish in a peer-reviewed journal. We have a 4% incidence of fat embolism syndrome. That means that 4% of people at least needed nasal prong oxygen and dropped their pulse oximetry below normal. 4%. Okay, 4 out of 100. It's not that rare. Okay, and that's taking every possible precaution. It's 4%. Okay. Now, most of those 4% breathed oxygen either by nasal prongs or by mask for a few days. The longest of them stayed a week in hospital. Okay, they got better, got discharged. By the way, any other hospital would probably diagnose you with what's called a pulmonary embolism, which is due to a clot. And in fact, all the tests suggest that's what you have, but it's not. And if you get treated for that, you get treated for the wrong thing. You end up on anticoagulation for the wrong thing. You could end up bleeding. You could many things because people don't understand that you have FES. Okay. So first of all, part of this is actually knowing and recognizing the condition. There's no real test for FES, by the way. So it's just based on experience and clinical diagnosis. Gotcha. Now, of the 4% that we had with this, we had to date 2 patients, okay, which of the 4% represent about 6%, okay, of the total group. that ended up in the intensive care unit. Okay. So it's a very small number, but those patients, those two almost died. Thank God, because at our hospital, we have all these things that I talked about, the availability of ICU, ECMO, everything else. We were able to save two patients. One ended up on ECMO, one did not. One just ended up long stay in the ICU, which, by the way, is incredibly expensive. And, fortunately, their insurances covered their stay, in the ICU. They did not end up with additional bills. But the bottom line, we saved both of them. Interestingly, there was one feature that both of them had that no other patient had in our group. They're both vapors. And so again, this is not ultimate proof, but we're suspicious that vaping causes enough non-recognized lung damage that if you add fat embolism syndrome to it, now you don't have enough lung tissue oxygenating. Okay. In other words, the vaping was the straw that broke the camel's back, but the vaping's invisible. I mean, you don't really see the lung damage from the vaping. So I will no longer do this procedure, the stature lengthening, on anyone who's been vaping in the past 3 months.
Okay.
And in fact, in a consultation, some of my patients will tell you, I'll turn to them and say, hey, so you're really committed to doing this lengthening? Absolutely. Yep. Proceeding when? And they'll give me a date. I said, okay. I said, oh, show me your vaping machine. And they'll pull it out. I say, so 100% you're committed. I open the garbage and I drop this expensive machine into the garbage. Okay. It's a little melodramatic, but the point is that, and look, I can't stop that. They're not fooling me. They're fooling themselves. They end up in the ICU. It's their, playing Russian roulette. Yeah. So fat embolism is scary enough. Add to it any other sources of lung damage, smoking, vaping, things like that. So we treat this very seriously. In the end, look, I've made a career, and I've said this before in your show, number one consideration for me is safety. Number two is safety. Number three is safety. At least till number 10, it's all still safety. Okay. And it keeps going like that. So to me, look, my biggest theoretical nightmare is to lose a patient, a healthy, normal patient who came to me for a cosmetic procedure. Okay. I mean, it just is, and those two patients that we had were both young. One was 25 and was 38. Wow. Okay. And I lost a lot of sleep over both of them. And there was nothing I could do to control it. I mean, if I'd known about the vaping thing, I guess I could have turned it, but both of them lied to me, by the way. Both of them were asked. And how did I find out? They told a nurse. So they lied to the doctor, but they told one of the nurses, and we found it in the notes, in the medical notes. And I said, I didn't know this patient was a vapor, so it's like, who are you trying to fool? I'm on your side. We got to be on the same team. If we're not on the same team with the patient and the patient is playing for the other team, a good chance you may lose. So
gotcha.
Anyway, that's a lot. I know I spent a lot of time on that, but I think that when you're going into this is the only, almost the only thing that risks your life. The other one is pulmonary embolism with a blood clot, but the risk of that is lower, and you can prevent that by anticoagulation and treat that with that. So
gotcha. That's a perfect segue into our next complication, because it is pulmonary embolism. So obviously you kind of touched on this previously, but yeah, if you don't mind, for the audience watching, what is a pulmonary embolism? How likely is it, and how can you prevent it?
Sure. So listen, pulmonary embolism is where you've developed a blood clot in one of your veins, usually in the lower extremity or pelvis, and there are big veins down there. And that clot, instead of just getting stuck in the vein, by the way, if it gets stuck in the vein, it plugs up. You got a lot of veins, so it plugs up the vein. You may get some swelling, but it doesn't go to the lungs, so it doesn't risk your life.
Okay.
If that blood clot dislodges, okay, the veins are going from narrower to wider. So if it dislodges, it meets no resistance, goes all the way up to the heart, like your arrows there.
Yep.
And the heart then pumps veins. The venous blood has low oxygen in it, okay? And it pumps it into the lungs to get oxygenated. So now it pumps this big clot into the lungs. The bigger the clot, the bigger the blood vessel it plugs. So tiny little clots plug little, kind of like fat embolism, plug a lot of little tiny vessels, less issue. Big clot can plug the main pulmonary vein, and you know you're ending up with you know you're ending up with basically stopping all blood flow into the lungs. You die. Okay, and that happens. What does this happen from? Any surgery, including giving birth. Okay, so this is a well-known complication of just about any operation. You know, it used to, and it's not talking about limb lengthening, but it's you know, female fat and 40, the 3Fs used to be the big risk factor, you know, for surgery in general, you know, for getting this. Hip fractures in older people, big risk factor. Knee replacement, big risk factor. You know, so in a lot of surgeries, this is one of the dreaded complications, and one of the reasons that people actually routinely anticoagulate after surgery, or at least take an aspirin to reduce, you know, so because it mostly develops in the hours to days after surgery. And the more mobile you are right away, the lower the risk. So that's why we try and get patients moving, walking, so their venous blood doesn't stagnate in their legs because it's being pumped by the walking and so on. We do see this risk in obviously in bilateral insertion of rods. We saw it when we used to put fixators. So, and certain people, by the way, are more prone to this than others. There are genetic factors that make you clot faster. So some people actually have abnormal clotting factors that increase their clotting, and they don't even know this. And they're a walking time bomb. They're going to have some operation, they're going to die, or they're going to get a fat embolism. I mean, pulmonary embolism. Now, same story with pulmonary emboli. So initially, you just need oxygen, you know, but you throw a big enough one and you can't oxygenate in the same scenario we just talked about. The only difference is you can treat it with blood thinners, and what the blood thinners do, they don't get rid of the clot. They prevent further clots, and your body has our bodies have checks and balances. They have a homeostasis system. So while you have things that cause clotting of blood, you also have factors that actually eat up blood clots. Okay, and that is always in balance. If it wasn't, we'd be more clotting or more, you know, anticoagulated all the time. So in a normal state, we are exactly even. Okay, it's the same thing in so many things. Like you have cells that make bone, you have cells that eat up bone, and that's also kept in equilibrium. Well, when you give an anticoagulant, okay, you're stopping the clotting. Now, you're not stopping the cells and the systems that eat up the clot. So you're changing the balance. It's kind of like if it's snowing and you've got snow plows on the road. The road, it's still snowing, but the road's clear because you're removing the snow as quickly as it's falling. But if you if you stop all the snow plows, the snow seems to accumulate on the ground. Okay. Or if you add more snow plows, you never see any snow on the ground, even though it's still snowing. You see what I'm saying? So,
Yep.
so your body has these things, and the anticoagulation is the way to change the balance. We don't have that for fat emboli. Okay, we don't have a way of, so that's why fat embolism is more dangerous in some respects than a blood clot embolism. For fat embolism, I did forget to mention one thing, which is that there are some things we can do. The type of reamers you use to drill the hole in the bone, if they have more open holes in them, they don't act as much as of a plunger. If you unplug them, and there's a certain way of doing that while you're reaming, and we're very careful about that, you're going to avoid that. If you go slower, you're going to avoid that. If you vent, make holes in the bone so that the pressure can go somewhere, you're going to reduce that. If you give IV albumin ahead of time, it catches some of these, the protein, which is the albumin, reduces the chance of fat emboli. So there's many things also in surgery for fat emboli, as well as pulmonary emboli. Our anesthesiologist in our OR is monitoring the pulse ox, the inspiratory pressure, how much resistance there is to inflate the lungs, because the patient's asleep, we're breathing for them, right? Yeah. And also the blood pressure. You'll see very subtle changes in those three. And every time I ream, I first go to the anesthesia. I said, watch the blood pressure, inspiratory pressure, and pulse ox, even though they know this. I act as if they don't know. And I say, I want you to say stop if you see any change. And occasionally they will say, and I'll slow things down. I'll vent more. I'll clean my instruments more, whatever it takes. So we are hyper aggressive. And interestingly, since then, our rate of fat emboli syndrome has dropped.
Wow.
Okay, so we did our study. We then re-educated all our anesthesia people. We re-educated ourselves. We did a whole bunch of additional things like the albumin and so on. And actually our rate has probably dropped to 1%. Okay. Wow. So I think we can actually reduce the rate that it occurs. Plus I now have arranged a deal with our critical care people that if I am even suspicious, if I see anything like a blood pressure change, inspiratory pressure change or pulse ox change in surgery, I have them meet the patient in recovery room and start critical care management right there. Wow. And that has also changed. So, like I said, we're all about safety. We've learned from this. We've really tried to get on top of it, prevent it, and so on. The last thing I'm going to say is an interesting thing about pulmonary emboli. We did a study also on pulmonary emboli and with the stride nail, and looked at 2018 till 2020 and 2020 beyond. So actually it was one study, but then when we looked at it, we noticed we had an increase in pulmonary emboli between January 2020 till they removed the stride, I think in March 2021. Okay. Yeah. We had an equal number of patients done from 2018 to 2020 and from 2020 to 2021. And we had 6 or 7% of our patients got pulmonary emboli from January 2020 on, and 0% prior. Wow. Now, that's very significant. And you know what we think caused it? What happened in the beginning of 2020? COVID. Right. What does COVID cause? It causes coagulation. Coagulation of the blood. And we think that a lot of these patients have subclinical COVID, were exposed to it, and it's gone. We're no longer have it anymore. So that have not seen a pulmonary embolism since mid-2021. And just for that 18-month period, the peak COVID period, we saw this rise in pulmonary emboli. And we were anticoagulating people with only aspirin. We went back to use Xarelto because of it. So later you're going to ask me, what do you look for in a surgeon? You look for what we're doing. You look for people who review their results, who do research constantly on their results, because only those people will pick up those trends. figure out what's going on, and improve. So we are not, yeah, we're the most experienced, probably the safest, the best, and so on. But we can get better, we can get safer, we can improve. And the only way we can do that is by studying our own results.
Wow, amazing. I told you guys, told you you're going to get the full deal today. All right, Dr. Paley, next up is a muscle contracture. Obviously, during lengthening, we know the soft tissues are the biggest culprit. So if you can just explain to the audience, what is a muscle contracture? What type of muscle contractures can they get if they're lengthening their femurs or their tibias? And then how can you prevent it?
Yeah, this is a great question. And this is the most common complication of limb lengthening.
Okay.
And the most common, so I'm going to use the word problem as opposed to complication.
Okay.
And I published a paper in 1990. It is actually the most quoted paper, a peer-reviewed paper I've ever published. It was called Problems, Obstacles, and Complications of Limb Lengthening. And what it defined is that, in fact, when you do lengthening, there are things that are, you know, problems, and we don't, they are a type of complication that's arising, but you can treat them non-operatively. Okay, you can do things non-operatively to resolve them. So, and a true complication is something that occurs and you may need surgery to resolve it, or it's not resolvable. Okay, so like to avoid these obstacles or obstacles when you can eliminate it by surgery, and a true complication is when it's a sequela. It's there. You now have a permanent, complication. So in most cases, muscle contracture is a problem. It can be resolved non-operatively. It can be resolved by stretching, physical therapy, things like that. Okay. So what's happening, of course, as we lengthen, and this is what makes lengthening different than other type of surgery. So in limb lengthening, it's what I call four-dimensional surgery. Most surgery is three-dimensional. What do I mean by that? So, you do, let's say, hip replacement, okay? In a 2-hour period of time, it actually takes most people less than an hour, you change the anatomy with surgery. You go in, you cut this, that, you put in a metal and plastic hip replacement, and you've now finished. And now the patient rehabilitates, okay? It's a finite time, done. Limb lengthening, you go in, you put these metal rods or external fixators on the bone, and in fact, you haven't done any lengthening yet. And then over the next days, weeks, months, you start adjusting this device, stretching the leg, and you are growing the bone and the muscles and so on. So the operation is not really finished. And if you define the operation as an anatomical change, that anatomical change is not really finished till, let's say, do 8 centimeters, a millimeter a day. That's 80 days and 7 days waiting till you start lengthening. So it's 12 weeks. It works out. Okay, 12 weeks later, the length has been achieved. That anatomic change. So the operation, in my mind, took 12 weeks. 4 dimensions. Time is a factor. Gotcha. And it's this change over time that means that the muscle's getting tighter every day. Now, the goal is to stretch and maintain the joint motion. And the only way you can do that is by stretching and by splinting. Okay. And muscle's a funny tissue. It's the only tissue we have that has its own ability to change length, right? So when you stand, when you, let's take the quadriceps muscle. When you bend your knee, okay, your quadriceps lengthens, okay? It elongates. And when you straighten your knee, the quadriceps shortens, okay? So the muscle fibers kind of do this and do that. And that's exactly what they do, by the way, is you have these molecules called actin and myosin that are exactly like my fingers here. And due to electric charges, they do that and contract, or they relax and allow it to elongate.
Right.
That's what a muscle normally does. Now, when you start lengthening, you want the muscle to maintain, if you added 2 centimeters, you want 2 centimeters longer muscles. Okay. Let's say that instead of the entire muscle getting longer, the muscle just gives up its excursion.
Right.
It just says, you know what? I don't want getting longer. I have to make more muscle cells.
Yeah.
I need lots of protein to build cells. I need lots of things to grow. It's a hard way. Easy way is I can just relax and allow my fibers to unwind. Now, muscle is still the same length. You try and bend your knee, your ankle, and it won't go because the bone's gotten longer. The muscle relatively just gave up its excursion. So now the muscle can move less because it has less excursion.
Right.
And that's what causes a contracture.
Gotcha.
So you've got a picture showing the Achilles tendon there and the gastrosoleus muscle, that's the calf muscle. Okay. So when you lengthen the tibia, okay, you are stretching the gastrosoleus muscle, which is connected to the Achilles tendon. Okay. That needs to lengthen. So in order to lengthen, you have to maintain the stretch so you can, on the bottom picture, dorsiflex, pull your foot up, 20 degrees that it normally goes up. If instead you don't manage to keep up the amount of new growth of the muscle with the new growth of the bone, okay, look at the upper picture, the foot only comes to 90 now, but not above 90. And then if you keep going, you'll get into what in the lay literature is referred to ballerina foot, or the technical term for that is equinus. Equinus means toe down, comes from equine, horse, okay, because horses walk on their toes in a toe down position, okay? And so basically you get this ballerina foot because the muscle didn't lengthen. Now, how do we get the muscle to lengthen? So to get the muscle to lengthen, we have to actually keep the muscle under stretch for about 6 hours a day.
Wow.
6 hours. Now that's very hard to do. So that's why, like if you come to our place, you wear these splints for the foot that hold your foot in a cocked up position.
Right.
And they actually sandwich your leg. Patients hate them. Okay. And they're always having to wear these braces. And the reason is they keep the Achilles under stretch. They keep the gastrosoleus muscle under stretch. And that's why, we are getting that muscle growth. Plus we're taking them off, stretching, doing additional stretch beyond that with physical therapy and at home, and encouraging the muscle to grow. Same thing when you're lengthening the femur, you got to stretch the hamstrings and the quadriceps muscle. Okay, that means you have to stretch in a straight position, stretch in a bent position. Okay, as you lengthen, you start losing bending of the knee. As you lengthen, you start losing straightening of the knee. And if you can't maintain that, we stop the lengthening. So everyone always asks me, why is it we can get up to 8 centimeters lengthening in the femur, but we can only get 5 centimeters in the tibia? Right. And the answer is the Achilles tendon is the biggest tendon in the body, and it doesn't grow very easily. You really have to hold it really stretched a long, long time. The second thing is, what you're not seeing here is that the gastrocnemius muscle, which is part of the Achilles, actually crosses the knee joint. It attaches to the femur. And so if you bend your knee, you're actually relaxing your Achilles tendon. And so you would have to, we're only splinting up to the knee. You'd have to really make people miserable and put them in a long leg type cast or splint that would hold their knee straight and their ankle cocked up. Most people won't tolerate that, and we don't do that, but we encourage them to sit with their legs straight, which stretches it. So what we find in most people is that when you get beyond 5 centimeters, they can't still get to 90 degrees. And we won't let people go into that ballerina position, the equinus position, because it's very hard to recover from that. Okay.
Gotcha.
Now, what some doctors do is they lengthen the Achilles tendon. Okay. So patients ask me, why don't you just lengthen my Achilles tendon? So that would solve the problem of being able to do more lengthening. But now they're permanently disabled. Why? Because when you lengthen the Achilles tendon, you lose strength of push off.
I see.
And the Achilles does not respond. It doesn't recover. In a child, it may. In an adult, it won't. It does not recover its strength. So you lose the ability to toe off. So when you walk, every step you're toeing off. So you end up walking very flat-footed, very heel, 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 instead of heel, toe, heel, toe, heel, toe. That's normal walking. You'll never jump again. You'll never run again. You know, I have a woman right now, and her doctor lengthened her Achilles tendon when he lengthened her tibia. Okay, she came to me. It was done with an external fixator. It has nothing to do with the device, by the way. It has to do with and she came to me to lengthen her femurs, and I saw the state of her feet, and she's walking on her heels. Literally, she cannot push down. There's no strength to push down. Nothing. I mean, it's the worst case I've ever seen of it. And I just did an operation on her, put her to actually create ballerina foot, to put her in a down position, cut the Achilles, shorten it, and actually try and create a contracture. And then I'm going to slowly cast her out of that. I want to get her the strength back, and then try. It still will never be as strong as before. And it's expensive to do all that. In addition, we have the opposite problem where people lengthen and they get equinus, or the ballerina foot. One surgeon in particular out of New Delhi, who honestly should be put in jail, in my opinion. He is harming people, and people are going to him because he charges $10,000, okay, for the whole thing. And he creates one ballerina foot after another, and I've had to treat people for this. Now, you could just lengthen their Achilles, and the foot would come straight, but they'd never have push off again.
I see.
Okay. So you can't do that. So I actually have to put on an external fixator, attach the foot, and slowly stretch the foot out of its equinus in order to correct it. And then they end up with their normal strength back. It's like a limb lengthening, but for the muscle and not for the bone. So all of these things, you got to know how to fix these problems. And one of the things we'll talk about later is, you know, what makes us as good as we are? Honestly, not our ability to put a precise nail in. Most people can put a precise nail in. What makes us as good as we are is our ability to make good decisions, and if things go south, how to treat the complications. So, absolutely. You know, plus most of the time we're preventing complications, but if they do arise, we know how to treat them. And that's what separates the really good surgeons from the ones who aren't as good. And we'll talk about how can you figure that out as a consumer.
Yeah, absolutely. And Dr. Paley, before we move on to the next one, a few people have emailed me a question leading into this muscle. They wanted to know, how flexible do you need to be pre-surgery? I know that I talked to your physical therapy team on one of my live streams back in May, and they mentioned pre-adjustment to the routine is very helpful for discipline's sake, but how helpful is it to the muscle tissue itself to prime for limb lengthening?
So, you know, when you do stretching at home, like you do, I do it for my rock climbing. I do it for, you know, working out in the gym. People do it before they go running, things like that. The effect of that is very short-lived. It lasts a couple hours, you know, if that. Okay. And then you're back to you know, some people are very flexible and others are not, right? So stretching is good. I'm not sure you can change how tight you really are by doing lots and lots of stretching before you start the limb lengthening. It's a good habit to get into because it gets you into what you're going to be doing during the lengthening.
Right.
So doing stretching, it doesn't cause harm. I'm not sure months of stretching in advance causes any lasting benefit. It lasts for about 2-3 hours.
Okay. Very cool. Awesome. Well, that's an awesome take right there. All right. The next one is a very common, I guess, theme, if you will, of the complications that we're going to discuss in a little while. And that is the topic of a delayed and a non-union. So for everybody watching, Dr. Paley, can you explain what is a delayed union? What is a non-union? How likely are they to happen, and how can we prevent them?
Yeah. So when we do this, let's take a step backwards and talk about how we get bone healing in the first place. And when you do limb lengthening, and this is what we really credit this guy Ilizarov, the Russian or Soviet surgeon who came up with this whole technique. And you're cutting the bone. Bone's a living substance, and it makes new bone. If you break a bone, bone starts making new bone to heal itself, and it literally makes kind of a mound bone around itself to glue itself together. Okay. And by the way, every other tissue in the body except for bone heals with scar tissue. Bone does not heal with scar tissue. Why is that? What is scar tissue? Scar tissue is a fibrous tissue. You look at a skin scar, and it is basically a tissue that's flexible. You can't heal bone with a flexible tissue. Okay. Scar tissue is full of collagen but it's rope-like. Bone has to be rigid, right? So if bone heals with anything but bone, that's what we call a non-union.
Okay.
It didn't unite. It didn't heal bone to bone. Okay. And so bone heals by making bone to glue itself back together again. Okay. And in fact, the limb lengthening process, you keep pulling it apart and you do it. Why do we go so slowly? Because that's the rate at which the bone cells can make more bone to fill the gap.
Okay.
If you go too quickly, you get a failure of bone formation and you'll get a non-union. Okay. If you go too slowly, you can get the opposite. You can get so much healing, it'll stop the bone. It's called premature consolidation. Okay. So bone is very strong. You can get to the point where the bone is stronger than the strength you have to pull it apart with the external or internal device. Okay.
Gotcha.
So the delayed or non-union in limb lengthening occurs for so many different reasons. So first of all, it may be related to how fast you're going.
Right.
While a millimeter a day may be a good average number, no single rate is good for everybody. And it's related to many factors. It's related to the inherent speed of healing of that bone. For example, the femur heals much faster than the tibia.
Right.
So you can go faster in the femur, you probably should go slower in the tibia. So we never lengthen a millimeter a day in the tibia. We never go past 1/4 millimeter a day, which by the way is also good for the soft tissues, because in the tibia, you got the Achilles tendon, which doesn't grow as well as the quadriceps. Okay. So the second thing is the diameter of the bone. The bigger the diameter of the bone, the more it can tolerate faster lengthening, and the better the bone healing is. So we're cutting bone in the middle, which is the slower area of healing. And if you get into forearm bones where the diameter is quite small, okay, there you can't lengthen faster than 0.5 millimeter a day. If you do, you'll get a failure of bone formation. Okay. The humerus, the arm, is even a faster healing bone than the femur. So you can definitely tolerate 1 millimeter a day there. So these are all things that you have to know. Right. And a lot of new limb lengtheners don't know this. And let's come back to that topic. Lots of people can figure out how to put in a precise nail, but they know nothing about limb lengthening. These are the basic fundamentals you got to know. Many things contribute to bone healing. Some are metabolic things like vitamin D. So today, because we use sunscreen, so we don't get skin cancers, and we avoid being out in the sun too much, and so on. If you measure people's vitamin D level, almost 100% of people have low vitamin D. It's an epidemic. And we measure it on every single patient we operate on now. And I would say 90% of people need supplementation. That's crazy, right? So normal level of vitamin D is 30 or above.
Wow.
Okay. And most people are less than 30. Vitamin D is an interesting thing in that it actually has a lot of positive effects, but it has very few negative effects, if any. And you can push its. It has very low toxicity, meaning you can, normally someone would say the normal range is from 30 to 40. You shouldn't go over 40. Right? In vitamin D, I'm not sure what the upper limit is. A lot of people feel it has longevity benefits. It was anti-COVID. It protected people from getting COVID. It has anti-cancer effects and so on. So purely for health reasons, I keep my vitamin D at 100. Okay. All right. I supplement 10 to 15,000 units a day, and I'm not having surgery. I'm not having anything. And I've been doing that for 5-6 years. Okay. And it's a good thing. So first of all, make sure your vitamin D has been checked. Okay. Again, that's something someone who is doing this a lot, they'll know that. And make sure that you're being supplemented by a high enough dose, because low vitamin D will slow your bone healing. Okay. So that'll give you a delayed union. When you break the bone, the way you break the bone, we break it through a 1/4 inch incision, less than a centimeter incision. Okay. And we break it with a chisel. Okay. So we make a few drill holes and then we break it with a chisel. Very low energy. We don't use a saw, for example. A saw burns bone. To use a saw, you have to open and, in fact, get enough exposure to use a saw. So that means you've already stripped the bone of a lot of its blood supply. All those things are bad for the bone. Okay. So the way you break the bone greatly affects how well it makes bone. One of the questions to ask the doctor: how big an incision do you make to break the bone? If they're making more than a 1/4 inch incision or 1 centimeter incision, 1/4 inch is 6 millimeters. It's less than but even a centimeter. They're not really an experienced limb lengthener. They don't have a lot of knowledge of doing this, because that's not what you should be doing. It should be done through a very, very small incision. The lengthening should be done not 1 millimeter all at once, but spread apart. Ideally, there used to be a motorized machine with an external fixator that did it once a minute, 1,440 something times a day or something like that. And just a tiny, tiny amount. We do it 1/4 millimeter 4 times a day, which is the original, and that's fine. Break it up. So for the tibia, where we're doing 3 times a day, we do 0.25 3 times a day. Okay. So we usually do it in 1/4 millimeter dose. That's called the rhythm of lengthening. So the rate and rhythm are critical. And then this should be monitored by X-ray. And if the X-ray is showing poor bone healing, it should slow down. If you're developing contractures, slow down or stop. So there are many of these decision-making things that make the difference of getting delayed or non-union. We have so this is part of what we do every day. Very few of our patients ever get a delayed union. And until now, I say that for the Stature group, I don't have a single non-union at all, not a single one. Now, in the tibia, what is more common is not a non-union, but you get a failure of bone formation in the front. And yeah, we do get that. That is because the tibia is right under the skin, doesn't have a lot of blood supply, and you enter from the front, and right there, it often doesn't make good bone in the front. And there are ways to treat that. Most of them never need surgery. The odd one will need some bone grafting of that area. Even though it's not a non-union, it's a failure. It's a partial failure of union in one area. And you can't get the rod out until you get that area filled with bone, because the bone will eventually crack there.
Right.
If you took the rod out.
Wow. Incredible. Awesome. All right. The next one that we have is, you mentioned this a little bit earlier, so there's not a whole lot of explanation needed here, but what is a pre-consolidation or a premature consolidation? And how often do you see this happening? I mean, is it more in the younger patient population, or can it happen with people who are, their caloric supply is a little higher? When do you see a premature consolidation happen?
So premature consolidation occurs when the bone, well, we see it in several situations. Classically, if everything's working on the mechanism, which is either the external fixator or the implantable lengthening rod, and you're lengthening, let's say, 1 millimeter a day or whatever speed you chose, 3/4 millimeter a day, premature consolidation occurs when when the bone itself makes so much bone so quickly during the lengthening, and it can occur at any time. It can occur, 1 centimeter, 2 centimeter, 3, that it bridges the bone faster than you can pull it apart, and it gets so strong a bridge that the device literally can't. The force of the device is not great enough to pull it apart. Okay, we see that mostly in kids with external fixation lengthening. Rarely see it in adults. Adults heal slower. Where we've seen it more with the precise nail is if the mechanism is failing or failed. And what's happening is you see a patient and it's only lengthened, let's say, it's 2 weeks later, at 1 millimeter a day should be 14 millimeters. And they only separated 5 millimeters. And so they're not lengthening as fast. The mechanism has failed, or the resistance to the lengthening is so high that the mechanism can't push. And so in those cases, we've seen premature consolidation. And the treatment, if you're truly convinced it's premature consolidation and not a failed mechanism, you can take them back to surgery, re-break the bone, and start lengthening again. But if the mechanism, so what you do is you cut the bone around the rod. You don't have to take the rod out. You crack the bone. You lengthen it in surgery. And if it doesn't pull apart, you have a broken mechanism. So in those cases, you have to replace the rod. Alternatively, if you're pretty sure the rod's broken, a rod's not working, replace it to begin with.
Gotcha. Okay. Very good. Another one that a lot of patients, are nervous about is a nerve compression or compartment syndrome. Can you explain what is a nerve compression, and what type of situations would a patient notice that this might happen, and how can you fix it if they do develop that?
So great question. So, and I've actually published a lot on this. Most orthopedic surgeons, they are not very, they don't enjoy operating on nerves. And I was trained differently, and I'm very comfortable and do a lot of nerve work, actually. People come to me for treatment of nerve compression alone. So nerve compression is where, the most common one is carpal tunnel syndrome, where you get some numbness in these 3 fingers and thumb. And And what's happening there is the nerves in your body, they run from the spinal cord all the way down to your finger or toe tips, right?
Mm-hmm.
And on the way, they pass different areas where they're going through tight soft tissue areas and areas with a tissue called fascia. Fascia is like this very tight band of tissue. Or they're passing around a bone, like as you can see there, the peroneal nerves wrapping from the back of the knee, and then wraps around the upper end of the fibula, called the neck of the fibula, and then goes into the muscles. And in the process, it gets stretched as it goes around that corner. In the median nerve, it goes from the wide forearm into the narrow wrist, and there's a band of tissue there that presses on it.
Okay.
Well, the peroneal nerve is probably the most common entrapped nerve from limb lengthening. And what happens is, normally, nothing to do with limb lengthening, there's a very narrow space, almost like a hole in the soft tissues. The nerve has a problem. It has to get from the back of the knee into the muscles of the front of the leg. Those muscles pull up your foot and toes. And in order to get there, okay, it has to enter the muscles, but the muscles are covered by a very tough tissue called fascia, okay? And there's no way to get in. So basically, a little bridge of fascia has formed to allow the nerve in. So the nerve's coming through, and there's like a bridge of fascia sitting on top of it. Yeah. Incredibly, I don't know if this was created to create work for orthopedic surgeons or if this was a design flaw. I'm not one to criticize, but it's like unbelievably tight, even in the normal state. It's like unbelievable that nerve even functions normally, because it is so tight, it would take nothing to cause that nerve to not be able to work because it's so tight.
Wow.
Normally. So you do anything to stretch that nerve, cause a little swelling, whatever. Yeah. And that nerve will start creating pain in your foot, because it creates pain in the lower end where it goes to. It starts paralyzing your ability to pull your foot up. You get a drop foot and so on. Not a good thing. Yeah. But so the treatment. So first of all, you have to recognize it. Right. So you have to recognize the pain that you're complaining of in the foot is actually coming from way up there at the neck of the fibula. Second of all, you have to, so what do? Can you keep lengthening? Do you have to stop? So you need to take the patient to the operating room, and you need to decompress the nerve. Now, most orthopedic surgeons are not comfortable with the anatomy there to decompress that nerve. And I've actually spent many, many years trying to train orthopedic surgeons to decompress the nerve. It's interesting. They're all familiar with decompressing the carpal tunnel. We're all trained, but they're not trained to decompress the, to decompress the median nerve, the peroneal nerve and the anatomy down there. So a lot of times they'll actually call a plastic surgeon or a neurosurgeon in to do that. I personally do it myself. I've decompressed more peroneal nerve than any surgeon in the world. There's not a week goes by that I don't decompress a nerve. Now, am I decompressing it because we're getting so many cases with peroneal nerve entrapment? No, the opposite. I'm decompressing it to prevent problems. Okay. So for example, certain types, I know now from having done these surgeries, what type of surgeries have the high risk of causing nerve entrapment there. So for example, you lengthen femur and tibia simultaneously, you're stretching the nerve at both ends. Yeah. And patients get a lot of pain, and it's all coming from the peroneal nerve. So if we decompress that nerve, they don't have as much pain. Again, if you're experienced, you know these things. Most surgeons don't know these and will not do that. Okay. So it does not occur very often, but it is something the pain from that entrapment occurs frequently. The actual syndrome where you start getting a drop foot and so on doesn't occur that often, but you need to know how to treat it. And that's when you suddenly realize, my surgeon doesn't know how to do that. They know how to put a precise nail, but they don't know how to diagnose or treat this effectively or early enough. They also don't know how to necessarily make the decision, can I keep lengthening, can I not? You paid all this money to get the length. So it turns out, and we've published papers on this, that if you decompress it immediately, like in the first few days, you can actually continue lengthening. Sometimes you may have to slow the rate a little bit, drop down a quarter turn a day, but you can keep lengthening. And the nerve will always recover. So that's the reassuring thing.
Gotcha. Now, there was a father of a son. He was getting this done internationally, and he contacted me and he said his son lost some function. I think he did develop some foot drop or drop foot. If that happens, is it reversible or is it permanent loss of function?
But by the way, you have to be careful because the lay public does not distinguish a drop foot. So in an orthopedic surgeon, to an orthopedic surgeon, a drop foot means a nerve entrapment or injury. So the muscles aren't able to pull it up, versus what the lay public refers to as ballerina foot, which is equinus, where it's a contracture and it's stuck in a down position. So I don't know if this guy was talking about one or the other, or both. But if it's truly a drop foot, which means the nerve is entrapped, and the nerve is therefore entrapped means it's damaged. It means actually, when you open this up, the nerve is being choked, literally being choked. Okay, and you actually, when you cut the fascia off of it, there's an hourglass deformity on the nerve. It's fat on one side, fat on the other, and then it's like squeezed together in the middle. You can actually see this, okay? And by the way, in the normal situation, it almost has an hourglass at that one place. I'm telling you, this was not well designed right at that location. It was like a setup for failure, and it occurs when you do a knee replacement. It occurs when you have here's a tibial plateau fracture. It occurs in many situations. And what do people do? They do nothing. They don't decompress the nerve. And it becomes permanent more often than not. Gotcha. The thing is, we've learned that if you decompress it right away, almost 100% of the time it recovers. Okay. So the prognosis, if treated correctly, is to recover. If they left it alone, didn't decompress it, it probably will end up being permanent.
Okay. All right. Well, that's good to know. All right, Dr. Paley. Here's another one. A lot of people get this done at clinics. Like you said, those clinics don't have enough experience. And malalignment of the bones when they're lengthening. You mentioned that people can lengthen into valgus or varus, and that can cause undue stress on the joints later on in life, long-term problems. So I have a picture here. A patient sent to me. I think this was a recent article that was done, and somebody sent it to me. So I wanted you to get your world-class assessment of this picture or this X-ray. What is malalignment? What causes it? And I guess how can you treat it?
Yeah. So this is called axial deviation, and that's a fancy word for, in this case, knock-knee deformity. Axial means going up and down, and as you can see, it's deviated from being straight. It is bowed. I don't think you can see my cursor, but it's bowed. You can use your cursor. It's kind of got that, the tibia veers off to the side all the way down. And the ankles should be together. You notice the knees are almost touching, but the ankles are wide apart. So this is called axial deviation, and this is very common, but it's a beginner mistake. Okay. And I'll tell you, by the way, you can see where this came from. It says GQ on the bottom. So this was that recent GQ article. And, I'll tell you one thing, if I was going to be in a big name magazine, I wouldn't send out an x-ray showing that I have no idea how to prevent this from happening. Okay. This is a beginner mistake by a surgeon clearly who, gets a PR and then shows the whole world that they don't know how to prevent this. That's bad. I mean, it's really bad. And not to say I haven't had this. I did in the early days before, but my early days are a long time ago. I started with implantable limb lengthening in the 1990s. We had the Ilizarov nail, then in the early 2000s, did 400 ISKDs. And in 2011, we became the first to do the precise nail, done I think about 3,000 of those now. So my, fortunately, look, we all go through our learning curve. You're asking later, how do you choose your surgeon? I mean, on a selfish basis, you'd like not to be someone's learning curve, because this is a learning curve mistake. Okay. This should not occur. And this occurred purely because of, there's no what's called blocking screw. You can prevent this by putting a single screw on the outside of the nail. So right there. Yeah, no, at the top, above the cut, right above the cut, right there. Your hand is there. Yeah. And you have to put a screw there on the day of surgery. And that will usually prevent this axial deviation from occurring. Problem now is this patient is going to be happy with their length, but they're going to be very unhappy with their alignment, and they'll probably eventually seek surgery to get that done. So anyway,
that's crazy.
Bottom line is, be careful that your surgeon knows these things. And this is the hard part of how to choose, where on the learning curve is my surgeon. And if I was a surgeon, and this is my message to, we don't do a lot of publicity and a lot of articles. We don't need to. But you know what? I think you should move up your learning curve far enough that you're not making these mistakes before you go out there and advertise that you do these type of procedures. It's not fair to the public. Unfortunately, this got published. I saw this and just about fell off my chair and thought, oh my God, seriously. And of course, the lay public reading this doesn't see what's wrong. It's just glaringly obvious to any expert in the field that this is just, a beginner mistake.
Right. Yeah. And let's talk a little bit about if somebody's lengthening their femurs, can it also happen in the femurs as well, like the axial deviation that you mentioned?
That's really interesting. So the answer is yes, it can. So axial deviation can also occur. By the way, you notice that the precise nail there is bending.
Yeah.
You see the bow, and that is not the surgeon's fault. That is, that's the material. It's a titanium nail. There are certain things you can do to minimize that bend, and it has to do with the starting point so that it's going to occur. So you put it in a little bit in a bowed position so it ends up totally straight when you're done. The level that you cut the bone can be lower down so that it can't bend as easily. He cut the bone really high here, which increases that bending. In the femur, you can get the same kind of thing because, again, large forces, titanium nail. Did not get this with the stride nail because it was so much stiffer. But one thing that happens in the femur, the tibia, when you stand up, and it's hard for me to explain in words without a drawing, but the tibia is, if you look at the line of standing in someone who is not crooked, the line coming from the center of the hip through the center of the knee to the center of the ankle, those three joints normally line up. Okay. And if you're bow-legged, the line from center hip, center ankle goes through the inside of the knee. Doesn't go through the center of the knee. And if you're knock-kneed, it goes through the outside of the knee. Now, and some people are normally bow-legged or knock-kneed and so on. But let's say somebody's starting perfectly straight.
Okay.
Then if you are lengthening on that it's called the mechanical axis. If you're lengthening on that mechanical axis line, you don't deviate away from that line.
Okay.
The femur is not on that line. Femur is at an angle to that line.
Right.
Okay. So because we're using an intramedullary nail, when we lengthen along the femur, we actually automatically cause a little bit of valgus, which this is valgus, axial deviation, automatically, every case. The titanium nail, however, bends into varus. If you look at, especially on the left, see a little bit of bowing inwards of the nail. The other one, you see it more. And it cancels itself out.
Okay.
So it turns out that the flexibility works in your favor in the femur. That the one thing you can't control in the femur is that you're lengthening along the anatomic axis, which is not that mechanical axis, which is from center hip, center knee. Okay, because if you look, the nail doesn't go from the center of the hip; it goes from the side of the hip. So it comes in at an angle, and that causes a little axial deviation. You rarely see any effect from the femur because there's a little bit of bowing that nobody can see. My eyes see it because I'm familiar with it, and it cancels itself out. You rarely get much axial deviation from the femur. So most of the cases, what you get is what you see here in the tibia, which is this bowing effect in the tibia. And, and therefore, since we know it's going to happen, you have to put these blocking screws in. You have to make your starting point a little bit more lateral. You make your nails long. There's a variety of things you should do to mitigate against getting that complication. Okay. And that's again what separates the men from the boys and the women from the girls, I guess, to be completely egalitarian.
That's awesome. Good assessment of that one. All right, so there's a couple more here, and then we'll blast through some x-rays, and then we'll do a Q&A at the end here. But Dr. Paley, the next thing I want to bring up is IT band release. A lot of patients who get this done, they're worried about getting the IT band release. Well, first of all, what is the IT band? What is its function? Why is it good to release it for, let's say, femur lengthening? And if you don't release it, what kind of effect can it have during the lengthening process?
Yeah, so the IT band is it's an interesting structure. It starts on the side of your pelvis, runs along the whole lateral side of the thigh, and attaches, as you see there, onto the upper end of the tibia. Okay. And so it's a good question. So what's its function? And by the way, it's why if you look, your thigh looks firmer and smoother on the outside, and it's softer on the inside because the inside doesn't have this IT band. So the IT band is a band of the stuff I mentioned earlier called fascia. So it is a band of this very tough fibrous tissue. It is about the thickness of a piece of paper, but imagine a piece of paper drawn taut. I can't rip it. It's really strong. I'm pulling, and this thing is, I mean, how thin is that, right? And yet I'm pulling as hard as I can. And that, it's kind of the body's way of using something very, very thin that has a very strong tensile strength. Okay. So why do we have this? It's interesting. I mean, you go back in animals, and this existed like in goes way, way back. Like much more primitive animals have this IT band. It's there. It didn't just arise in humans. Okay. In humans, its role is several-fold. It is a tight band that resists so when we stand on one leg, so every time you take a step, you lift the other leg up, you need, it's called a tension band. It resists the bending force. So when you stand, your leg wants to buckle this way, right?
Mm-hmm.
Because your whole body weight, your pelvis, the body weight's in the center, and you're standing on one leg and the legs are apart. Take one leg off the ground, your whole body's out here and it wants to drop down, right? And everything resists that. So all your muscles on the side resist that bending to the side. Okay, so when you walk, you don't limp because everything's tight on the outside. Okay, your muscles get tight. And it resists the knee from going like this. If you didn't have the IT bend, the knee would see a much bigger force like this, which would put a lot of force on the inside of your knee.
Right.
Okay. It's connected to two big muscles at the hip, the tensor fasciae lata and the gluteus maximus. And every time you take a step, they pull on that band. Okay. To pull on it. But it is so tight that if you don't cut it, that it will put tremendous forces on your knee. It'll make it so you can't straighten your knee all the way. It also causes your leg to turn inwards. Okay, so internal rotation. And it's attached at the hip, so it flexes you forward. So again, causes one of these things that's referred to in the lay literature as duck-ass deformity. That duck-ass is coming from tightening of this band. Okay. Now, it's been recognized for the first article I ever saw that talked about this thing getting tight and lengthening. This was when they only lengthened for one side. It was in 1956, the year I was born. So it's been recognized for a long time that when this gets tight, it resists lengthening, it causes deformities, it causes all kinds of problems. So, and they even back then recommended cutting it. Again, part of the learning curve is that if you don't cut this, patients have all these other deformities. They can have the duck ass, they can walk wide-based because you can't bring your legs in, and the feet turn inwards, and it causes issues at the knee and so on. Right. So, I mean, back in the late 80s, I started cutting this in the right situation. And you cannot do a large lengthening. Now, so the next question is, you know, here I gave this whole lecture about don't cut the Achilles tendon, you know, because it causes. So what's the effect of cutting this? So this is not a muscle. This is fascia. And it doesn't lengthen very well, but there's really very little downside to cutting it. So when you cut it at this level that you see there, it regenerates with the lengthening. And we come back at the end of the lengthening, you find there's no gap there. In fact, I've had to go back in for certain things, and the fascia is fully regenerated. Like I'd never been there. And so there's very little downside if you know how to cut it and where to cut it and so on. Never cut it higher up. In the middle, you'll get a muscle hernia if you do, and that looks ugly. You cut it here at the knee. Other than the little scar on the side of the knee, you don't really get any issues. Again, people who are starting out don't know that you need to cut this. I've published this. It's in my article on stature lengthening. You need to do that. And if you don't do it, you end up, like I said, with lots of contractures and other problems. In some cases, despite cutting this, and this is a small number, probably 5% of cases, this is very long, goes all the way to the hip. It still causes the wide base gait, can't bring their legs together, and sometimes still some of the duck ass. And in those, you actually have to release it at the top end. So we also occasionally have to do that. And now we've learned to recognize which are those patients, and we can test if we can't bring their leg across the midline, we're pulling the leg to cross the leg and it won't go. You actually have to release it at both ends at the start. And again, there's a technique for that. So part of the learning curve. So all of a sudden, limb lengthening is getting more and more complicated. It's not just sticking in a precise nail. It's making decisions when to cut the IT band, when to cut the upper end, and so on.
Mm-hmm. Yeah, no, that's huge. I think that's, yeah, because you have all these athletes and people with these really tense muscles, and that can change, you having to go in to, nick their IT band. Okay, I think our last complication, or I guess procedural here, is what happens to the bone marrow during the reaming of the intermedullary canal of these long bones. So obviously you mentioned this earlier a little bit, but a lot of people have asked me, like, what happens to the bone marrow? You said earlier about fat. Can you tell us a little bit more about that?
Yeah. So, the role of bone marrow is it has the stem cells in it that make blood cells.
Mm-hmm.
Makes red blood cells, white blood cells, so on. Very important. In children, that's happening in all the long bones and in the pelvis.
Mm.
In adults, it's pretty much limited to the marrow that's in the pelvic bone. And the pelvic is a very spongy bone. Spongy is kind of like the top of that bone there, or the bottom of that bone where it looks spongy there.
Yeah.
And pretty much those are the only, the pelvis and sometimes the spine bones, the only place that are actively producing stem cells and blood cells. And the long bones have stopped that function. And that's why they fill with fatty marrow. You have so much production and so many cells and so many bones, you never have to worry that if you stick a rod inside any long bone at any age, has any negative impact on what the marrow is tasked to do. Okay. So, and the moment you pull out the rod,
mm-hmm.
The inside of the marrow cavity will refill with the marrow that's supposed to be there, including fat. A lot of it will be fat again, Right. So it's called fatty marrow. So nothing anybody needs to worry about, except for the fat embolism part.
Right. And that's why you do that. You invented that technique, venting and all that good stuff. All right.
Right.
So real quick, Dr. Paley, we have about some patients that submitted their x-rays from where they got it done at other clinics, and they had a patient plea because I told them that Dr. Paley was coming on. So I'm just going to read their synopsis, their symptoms, and then their patient plea, and then you can just give a quick assessment of each case. So first up, we have patient 1, who was a quadrilateral patient. He used the Ilizarov ring fixator, did the lengthening of nail tibia on the tibia back in December 2021. He distracted 5 centimeters with it. He had his fixator removed April 10th. He also did his femurs with the precise tube, but that's not super important. But the symptoms that he presents with are poor bone regenerate in his tibias, and it's been about 10 months post-op. And he says, my tibias look to be healing really slow. I'm looking for suggestions. Also, I would like to know if walking with no aid is possible at this point.
Yeah. Gosh, there's so much more wrong with this case. And I will point that out in a minute. Yeah. Before we get to the bone healing, you notice there's no fixation of the fibula at the lower end or the upper end.
The distal or the proximal?
Smaller bone.
Yeah.
So when you lengthen only the tibia and you don't fix the fibula, the lower end of the fibula starts migrating up.
Floating fibula.
Okay. Yeah. If you look at the gap in the fibula, it's shorter than the gap in the tibia. Tibia gap is longer. And that's because the fibula has migrated upwards at the bottom. By the way, let me explain to you what's going to happen to these ankles. Let's say the bone heals, everything else, patient goes to normal. This patient is almost 100% getting ankle arthritis in the next 10 years.
Oh, no.
Yep.
Wow.
This is 100% preventable. Okay. 100% preventable. So the fibula, the fibula is kind of, it's not your main weight-bearing bone. Its most important function is at the ankle. And at the ankle, it serves a very important role. At the knee, it doesn't participate in terms of it's not in the knee joint, but at the ankle it is.
Yeah.
And if the lower end of the fibula goes upwards, so the fibula relatively shortens, then over time you get arthritis. To give you an idea of how little shortening you need to get arthritis of the ankle, so people who get ankle fractures, nothing to do with lengthening, just break their ankle, they break the fibula. We know that it takes 2 millimeters of shortening. That is, okay, 1/12 of an inch, tiny amount. If you have 2 millimeters of shortening, you're likely to get arthritis of the ankle. This fibula has risen up way more than 2 millimeters on both sides. Okay, so this is a future disaster for this patient. Number one.
Yeah.
Number two. Okay, so I fix the fibula at both ends. Most people fix the fibula only at the lower end. Why do I fix it at both ends? At the upper end, it has something else. It's attached to a ligament, the lateral collateral ligament of your knee. And if you don't fix it there, it'll pull down a bit. And when it pulls in the lateral collateral ligament, it can actually make it difficult for you to straighten your knee. So you can avoid that. The second thing is, if you don't fix it at both ends, it may prematurely consolidate the fibula. So what some people do, and I think this person did it, they'll go and remove a segment of the fibula. They'll take a segment out, thinking then it won't pull. But then you get a non-union. You actually get an area of the fibula that never heals. And that is a problem in many, many ways. First of all, the migration of the fibula at the bottom. Second of all, so ankle pain. Third of all, if you ever pull the tibial rod out, all the stress goes on the tibia. You have a higher rate of refracture of the tibia if the fibula is not united. So, I mean, there's so many things that, people just do silly things. Now, let's talk about the main question you asked, which is the bone healing. So I agree that the tibial healing is slow. It looked like it was regenerating and then it kind of stopped. Right there, there's beginning of bridging. So what I would do, it looks like they actually, was this a lengthening over nail or was this
this was a lengthening over nail,
Okay. So so if it was with an external fixator, they may have put a wire across tibia and fibula at the bottom, which is why we don't see it through there. So that may not be as bad as what I explained, but if it's a implantable nail, you need to use a screw. But so what you can do at this stage, first of all, like I said, check the vitamin D level, make sure you're getting lots of vitamin D, lots of calcium. Secondly, you can give an infusion of a drug called zoledronic acid or Zomida. And what that does, remember we talked about that homeostasis? So there's homeostasis of bone formation and bone resorption. That means removal. So it knocks out the bone resorption. Okay? Yeah. So the snowing analogy, it knocks out the snow plows. So now you're not removing the snow. So the snow, it hasn't snowed any faster, but it seems to accumulate because there's nothing removing it. Right. So you're always making new bone, you're always removing bone. But if you stop if you stop the removal of the bone, which is what Zomida does, the bone seems to accumulate faster. Okay. And so it turns the balance in favor of bone making and away from bone removal. And so sometimes that you can do up to 2 doses of those about 2 months apart, and that will sometimes get it to heal non-operatively. If you've got a precise nail still in, you can do the accordion maneuver. You had that listed earlier, and that's where you get it to cycle back and forth, like, half or 1 millimeter a day kind of compression distraction, and that kind of stimulates the bone to heal. Those are the main things. If you have a complete failure of bone formation, and that used to occur when we used to use the ISKD nail because you couldn't control the rate of lengthening, there we've had to do bone grafting. And if it's complete failure, we've had to take sometimes a cadaver graft, a whole segment, and put it in into the graft. If it's just a small area, you can take some cancellous bone from the pelvis or from the femur and put it into the gap. And then you got to make sure you have a strong enough rod. That rod looks a little bit small, and so if you don't have a strong enough rod, there's a little too much movement. Sometimes the fibula heals prematurely, which prevents compression on the tibial side. So sometimes you have to cut the fibula so that the tibia can feel some of that compression. So there's many, many things to consider doing. I would start here with vitamin D and Zometa.
Okay, that's awesome. Very cool. Well, I'm sure this patient is watching. Okay, next patient. This is a bilateral femoral stature lengthening patient. They use the newer version of the Albizia nail, the G nail. As of June 2nd, 2022, they lengthened 4.2 centimeters. They resulted with a 4 millimeter discrepancy. His surgeon told him that it won't cause issues. However, he was unhappy with the G nail after using it. He decided to leave the discrepancy and avoid having to continue using the painful clicking distraction method. His symptoms are that he presents with left knee pain, weakness of the TFL, the tensor fascia lata. He believes that his pain is due to protruding proximal screw, as you can see in the little illustration here. And he's wondering if this pain is due to the ratcheting that he was distracting, causing the torque of the connective tissues. And he says, I still have quite a bit of pain from the screw on my left side. I can feel weakness and pain in my knee every time I walk on my left side. Any ideas on how to quell this knee pain? I'm not sure if the screw is rubbing on the IT band, and should I get the screws removed earlier before the nails?
So I can't see the knees here, this picture of the hip. So, whatever is happening at the knees, difficult to comment without seeing those x-rays. Definitely the one screw there on what's the right hip, that is protruding and it's rubbing under the fascia lata, and it would be quite irritating. And often that upper screw or two can be irritating. So the bone's well healed. You can, at the very least, remove that screw. And I don't know how long out it is, but very soon you're going to be able to remove the whole nail. Regarding the 4 millimeter difference, patients get totally bent out of shape. Hearing, you think you're telling them it's 4 inches. You're talking an eighth of an inch. You have to understand that up to a centimeter difference, up to about half an inch, there are no symptoms. And if no one told you that you had half-inch difference, you wouldn't know. 10% of the population, 10%, 1 in 10 people are walking around with a 1 centimeter leg length difference and don't know it. So yeah, 4 millimeters is insignificant, and I wouldn't stress over that. I think it's more of a psychological effect than patients saying I can feel that, because I really don't believe that they can feel that. I think that they just don't like the idea that they have a leg length difference. We use an EOS scanner which takes an X-ray from head to toe, and we always measure beforehand, because almost every patient has a few millimeters difference before they start. And we do offer everyone that if they want to, we can stop the lengthening a little early on one side and keep lengthening on the short side to make it equal. And by the way, the majority of patients say, no, I lived with that before, but I don't want to give up any height. Whatever. It wouldn't make a difference either way. But bottom line is 4 millimeters is not important. There's no such thing as weakness of the TFL. I'm not sure what they mean by that. As I showed you, the TFL is mostly fascia, and not really a muscle. So if they have some weakness, they need to work on whatever the weak muscles are. You can get weakness of your gluteus, which are your hip muscles, and that's very common. So that's my thoughts on that.
Okay, very cool. Patient number 3. This patient was actually a leg length discrepancy patient. She had congenital constriction band syndrome. And basically, the discrepancy was corrected via lengthening on her right tibia, 40 millimeters. And she used the 10.7 precise 2 nail. She has partial defect and some valgus in one leg, she said. Now, the symptoms that she presents with are right knee pain. She believes this pain is due to the protruding proximal screw in the front, which I actually should have put the arrow here on the screw. And she's wondering if the pain is due to the ratcheting, or no, sorry, screw. I copied that over. If you look at the top of the rod, the precise nail, she says that it's protruding out of her tibia, and is wondering if this is the knee pain that she's having. At the top
so
here.
her knee pain is related. Yeah. So, the starting point of the nail is really important. It is 100% under the surgeon's control. And one of the most common beginner mistakes is not doing the correct starting point. So for example, for the tibia here, the starting point is too low. Starting point should be higher up on the tibia and should be almost inside the knee joint. There's a special area on the very top of the joint surface of the knee where the starting point should be. A lot of people actually make the mistake here. In fact, I won't say names, but some so-called very experienced limb lengthening surgeons have put nails at too forward a starting point. And what it causes is several things. First of all, the bone, you can't get your knee fully straight because I don't know if you can see, this bone is a little what we call flexed. So it's a little bit bent, bowed. And I'm not talking about the valgus, but on the side view, it's a little bit bent. And so that prevents the knee going all the way straight, right? That line in front of the tibia is not parallel to the line in the front of the lower part of the tibia. That line is that. That's about 10 degrees. That's 10 degrees you can't straighten your knee. And that makes you miserable. And that has 100% related to the starting point. It is what we call an iatrogenic deformity. Iatrogenic means caused by the doctor. And you can prevent that by getting the correct starting point. Okay. So I'm not saying this to criticize any specific doctor, but it's related to, where you start. And this is something, again, beginner mistake, learning curve. You can get this if you get it in the correct position. The second thing is, occasionally you do get a correct starting point, but it still goes that way. And then you have to use a blocking screw, which I mentioned earlier. You have to put it behind the nail to prevent that. So it's something occasionally will happen to me, and I will recognize it in surgery. I'll pull the nail out, I'll put the blocking screw, I'll put the nail back, and the leg straightens out immediately. The key is not to leave the operating room with that. Similarly, you can put the nail in and it goes into valgus. This one looks like it went a little into valgus, related to starting point, starting too medium, too much to the inside. So there's a lot of these little things that are really important steps in order to get it right.
I see. Okay. Very cool. Experience of the surgeon. All right. Patient number 4. This patient had bilateral femoral limb lengthening surgery, November of 2021. It's been about 10 months, precise 2 nail. She was worried about delayed union leading to a non-union. So she used PRP in early March of this year. 1 month later, her x-ray showed some callus formation on one of her legs. Now, she's just basically worried about the formation of bone primarily. She also had a Forteo injection, and that was in between May and June. Yeah, Forteo. Yeah, that's what I should have put that. And she's wondering, what are the solutions for her poor bone regenerate in the lengthened gap? What could be causing the excessive tightness of her hip flexors leading to duck ass? And does she have nerve damage from her left hand being numb?
Yeah. So, there's a lot of things going on. So first of all, I don't think PRP injection makes any difference in bone healing. None. No proof for that, and no reason it should make a difference. If you're using, some people will use bone marrow aspirate. where you suck some bone marrow, you concentrate it, and then you inject that in order to get the bone stem cells. I'm not a big believer in that. And the reason is because the FDA allowed amount that you're allowed to concentrate it to is and grow it to is an order of magnitude lower than what the studies show you need in order to get it to heal. But some people feel that helps. I personally don't, but I don't think it causes any harm, but it's expensive. I mean, people like it because it's minimally invasive. You know, it's just a needle, but it is a procedure. You have to be put to sleep for it and so on. So the fact that it's healing like that, that's good. Forteo is a parathyroid hormone. That is actually one more thing. I'm glad that, this came up because we talked about the Zometa, and that is stopping the bone resorption. The other end of it is increasing the bone formation, and Forteo is parathyroid hormone, and that is a way to kickstart bone healing. So, and you can only do this in adults. You can't do it in kids. Forteo causes tumors in children, so you don't want that. But in adults, you can use it, and and you can use the combination. Combinations can be incredibly powerful. So sometimes we do use Forteo, and we do use Zometa, and we sometimes use them in combination, and vitamin D. So these are all metabolic ways of doing it. Injection of, as I say, bone marrow concentrate. Some people do that. I personally don't. And you know, there's other things, inserting BMP, which is quite expensive, bone morphogenic protein. So there's many things to do. And then we talked about the accordion method and so on. To say that in the femur, I just have not had delayed healing hardly at all. And I've never had to bone graft one in the femur since I started using the precise nail. I did when I was using the ISKD, as I mentioned earlier, because it didn't control the rate very well.
Right. Okay. Very cool. All right. The next patient, we only have two more patients, and we'll get into how to pick a good surgeon. This patient had bilateral femur lengthening as well, using the G nail. He's doing okay, but he's worried about the same thing. So we'll kind of just, I guess this is just like a bone formation issue. If you look at the lateral view of his left leg, I guess it seems a little faint in that gap there. I guess he's just looking for, should he get a trauma nail swap, bone graft, or those other methods I guess you talked about?
So again, you know, bone healing issue. You know, swapping a nail, the advantage is that you get a stiffer nail, one-piece nail, as opposed to these telescopic. And it's not a bad idea. It does several things good for you. One is you ream the inside of the bone, and that stimulates bone healing. And the second thing is you're putting in a stiffer nail, often one that you can walk on, and even the walking, of course, helps. The downside is an additional procedure, and since insurance usually doesn't cover anything related to a cosmetic procedure, it's additional cost. So, but yes, after a very long time, it's a really nice way to get going, put more weight, and encourage healing.
Okay, very cool. All right. This case, I think what we'll do, this case is, again, it's the same thing really, but he was worried more so about a deformity of his tibia near the top.
This is exactly what we talked about. Look at that flexion. This is exactly wrong starting point, no blocking screw. They actually got a fracture. You see that big fragment there that broke, which happens. But what they didn't do, the moment you got that, you lose posterior wall of the tibia. You're going to go into what's called procurvatum or flexion deformity. And what they should have done, taken the nail back out, put in a blocking screw, put the nail back in with the blocking screw, and it would have controlled this. But they also didn't start high enough and posterior enough. So all of these things, again, these are common mistakes. A lot of times they're beginner mistakes, they're learning curve mistakes. But even if you get them, you got to know how to, you can't leave the operating room with this.
Yeah.
Okay. And this is part of it. One more thing, by the way, see the level they cut the fibula. It's a very safe level, the nerve far away from the nerve. The downside is the longer the segment of bone between the tibial bone cut and the fibular bone cut.
Yeah.
Okay. That level and that level. There's a bridge of fascia, that's called the interosseous membrane, that pulls between one and the other, and it helps to pull the tibia into that flexed position. So cutting the fibula higher up will reduce that. And then another thing, see the way they put their screw for the fibula, that fibula has migrated up, even with the screw.
Wow.
And the reason is, so you should always put your screw with it shouldn't be horizontal like that. The screw should be inclined, the other way.
The other way.
That way. And screw should be inclined that way. And secondly, they never fix the upper end of the fibula, so there's a good chance they're going to get premature consolidation of the fibula. There's just so many mistakes in this. Their starting point is way lateral, and you can, on the left leg, and you can see the leg has gone into varus deformity.
Yeah.
So, look, when we're charging people large amounts of money for this type of treatment, this is not what they should expect.
Yep. Yeah. No, that makes sense. All right. Last little thing here. This was more of a patient just asking about, is there any way to kind of outdo the biology of the body? This patient was saying he wants to be like Wolverine, and lengthening. Him and his coach came up with this special max speed regeneration super anti-catabolic protocol with growth hormone and other peptide hormones. And he's basically asking, if I do a crazy amount of physical therapy, can I sustain the 2 millimeter per day distraction phase speed until completion without causing a non-union if I take all of these, exogenous substances?
So first of all, it's not even just about the bone regeneration.
Right.
I've talked a lot about the muscle, nerves, everything else. So even if theoretically you could rev up the engine faster for bone healing, you won't necessarily rev up the engine faster for soft tissue regeneration. You're going to get all kinds of complications. And I have had people on all kinds of cocktails, and occasionally, again, it's very non-scientific, it's anecdotal. You'll say the bone healing's a little bit faster, maybe. One case that comes to mind was actually a 66-year-old woman, and her husband was one of these naturopath doctors, and I have to say, she healed like a 16-year-old. Now, I lengthened her 3/4 millimeter a day. I did all kinds of things at my end to maximize bone healing and soft tissue, and she did phenomenal. Can I say it was the cocktail? It didn't hurt. If anything, she healed remarkably well. She did really well. But we also didn't lengthen at the normal rate. We went the other way. We went slower. So honestly, people who are talking this way and considering this, I understand on a science fiction level, this sounds really attractive. But honestly, you want to supplement your healing, fine, but we're not going to change the protocols. The only way to do this safely is to follow the protocols that have been proven to work.
Right.
Okay. And by the way, I'm looking at some of the stuff in this cocktail.
Yeah.
So just to point out, IGF-1 in high doses like that also can lead to tumors. So you are playing with fire. Okay. Wow. So it can lead to basically stimulating cancer. On and on and on. So anything that increases cell reproduction, which is part of regeneration.
Mhm.
Okay. I guess Wolverine never got cancer, but you know, Wolverine's not a real person.
Right. That's science fiction.
And, exactly. So,
Okay.
you're taking your life in your hands. I mean, how many people have supplemented with steroids and ended up, I mean, and look, it's one thing to supplement some testosterone if you're low, and there's many uses for it.
Mhm.
But at a certain point, you're increasing atherosclerosis, you're increasing all kinds of health risks. So there's that line between, the health benefit, building muscles, and shortening your life.
Absolutely.
So
Absolutely.
it's the difference between crazy and healthy. And
Right.
sometimes that line is very, very thin. Stay on the healthy side of that line.
Absolutely. Yep. He said it before. Safety, safety, safety. All right, Dr. Paley, we just have a few submitted questions, and then we'll talk about picking a safe surgeon and take 10 minutes of answering patient questions live. Okay. Submitted questions. They were saying, why not lengthen 3 times slower to allow the muscles to heal? Yeah, I guess that's kind of, well, you mentioned that actually earlier about the soft tissue. But why not lengthen faster, create a non-union, and fill the gap with stem cell injections?
Yeah. So lengthening too slowly, we're going to get a premature consolidation.
Okay.
Lengthening too slowly, on a device that's non-full weight bearing, you're going to be, on walker or crutches and wheelchair for a long period of time. So that's not really, so you got to take a balance between what the bone can tolerate and what the soft tissues can tolerate.
Okay.
Gotcha. Lengthening too fast is not just an issue for the bone, it's actually a bigger issue for the soft tissue, the nerves, the muscles, and so on. And stem cells do not heal your bone. That's just a complete misconception. Doing stem cell injections has not gotten bone to heal. All right. Anyway, it's too long a discussion. But look, orthopedic surgeons should be experts in bone biology and understanding it. A lot of this too fast, too slow is, you got to understand your biology.
Yeah.
You can't, it's not like a motor that you press the gas pedal and you go faster. There is a limit to how fast it can go. And then even if you go faster on the bone, it doesn't mean the muscles or the nerves can handle it. So based on current knowledge, and that's going to change, and we've improved, and what we know today versus 10 years from now is going to be different. But based on current knowledge, we're going as fast as we're able to. And we're going, we're balancing the bone and the soft tissues. And that's what you want to look for. If you're going to be a patient, then seek out the best advice possible. Asking questions is great, but again, stay safe, don't stay crazy. Don't become crazy.
Love it. All right. This third question here, this kind of segues right into the how to pick a safe surgeon, but this was sent to me from a prospective patient. They said, Dr. Miami Beach, which is Dr. Tarek Hussein. He's a popular, I guess, plastic surgeon on social media. He's in Miami Beach, and they call him Dr. Miami Beach. And he does cosmetic surgeries, but he's also quadruple board certified as an orthopedic surgeon. He's planning, I saw an article that the patient sent me, and it said that he's planning to get into limb lengthening, stature lengthening. He said because he does a lot of Brazilian butt lifts and all this other cosmetic surgery. Does having a following like his, if he gets into this surgery, help or hurt the current state of affairs around limb lengthening?
Yeah, I don't know Dr. Hussein. I don't know about him. It doesn't say anything that he's an orthopedic surgeon. You said he's, I don't even know what you guys mean by a quadruple board certified plastic surgeon. I think that's mumble jumble, completely misleading stuff. Is he board certified in some kind of cosmetic and aesthetics and this and that? You know what? I don't see that he's an orthopedic surgeon at all.
Okay.
you haven't presented that. If he is, sure.
Okay.
This is a bone procedure, and if he's a board certified, fellowship trained plastic surgeon, okay, he's not an orthopedic surgeon. He has no business doing this procedure. The only reason you get into it is for mercenary reasons, to make more money and offer a service that he knows nothing about. Now, if he hired an orthopedic surgeon who is an expert in limb lengthening, and just like I'm going to say, not every orthopedic surgeon, they're board certified, should be doing this. They need to know about lengthening. They need to know, about the whole process. It's not enough to be a board certified orthopedic surgeon. When I started doing this, and my first cosmetic case was 1988, a long time ago. It's 34 plus years ago. And I started limb lengthening, a year before that. And then I got my first cosmetic a year later. But when I started doing this, this was very unaccepted. The techniques were much cruder. I was most worried about doing it safely and the not getting a bad reputation from, crippling people and so on who are totally normal.
Yeah.
As the techniques have gotten better and easier, more and more people want to get into this. And this is scary. And I'll tell you why it's scary. Because this is not like any other form of cosmetic surgery. Most cosmetic procedures, you mentioned butt lift, facelift, boob lift, breast augmentation, tummy tuck, nose surgery, et cetera. Ears, all this. It's not that they don't have complications. And it's not that they don't have unhappy patients. But what are they unhappy about? They may have some pain. Most of the time, they just don't like their scar or the appearance of something. Can they go to work? Yep. Can they walk without a limp? Yes. Have you decreased their ability to do sports? No. And, what's the risk of dying from those procedures? Most of those, almost none. Okay. Get some anesthetic risks. That's it.
Yeah.
This is a whole different ballgame. You've got to be an expert about fat embolism, about pulmonary embolism. You've got to be an expert about bone healing. You've got to be an expert about limb lengthening and muscle lengthening and growth and nerve issues. And the list is, if by the end, if you listen to the whole program and you haven't walked away from this with a healthy sense of, caution, then you're missing the point. You're so wrapped up in your desire for increased inches, you're missing the whole point, and you are at heavy risk of being handicapped and crippled. And you know what? I'm doing the best to keep you out of trouble by telling you what the stakes are. Yeah. But the stakes include, assume you don't die from fat embolism and so on. The stakes are, you will never play sports like you did before. The stakes are, you will never run like you did before. Stakes are, you're going to have a limp. Stakes are, you're going to have chronic pain. Stakes are that you could have arthritis of your joints prematurely. The stakes are that you will have some type of disability. That's the stakes. Yeah. I don't know any cosmetic plastic surgery that Dr. Hussein does that has those kind of risks. It doesn't. Okay. And you know what? I see the results of a lot of surgeons from around the country who are so-called experts. And I think they're good orthopedic surgeons in general, but they may not be experts. in limb lengthening. And even the so-called experts, I see complications from all of them. And they include things like compartment syndrome, where, you know, the muscle dies due to swelling, okay, especially in tibial lengthening. I see nerve paralysis, where you got a permanent drop foot, okay. I see contractures where, you know, and you can't get your knee or ankle straight. I see, you know, neurologic problems like drop foot that we mentioned, and even worse, okay, sciatic nerve injury, and so on. I've seen, you know, the bone healing problems we've already talked about ad nauseum, crooked bone problems, bone, you know, non-unions, infections of the bone, and so on. And I've got these from all over the world, because I treat patients from all over the world, and people are going overseas to save money. They go to Greece, they go to Egypt, they go to, you know, India. They used to go to China. China is a perfect example. China has actually made this illegal.
Wow.
It's actually illegal for an orthopedic surgeon to perform stature lengthening in China. Why?
Wow.
They have so many disasters and so many complications that in an authoritarian society, they can shut it down, and they shut it down. It's illegal to do limb lengthening for stature in China. And they were the leading country in that field. I actually visited their limb lengthening centers for stature many years ago. So, you know, there's a reason that happened. So you know, anybody who's logged on to this program, I applaud you, because you're clearly trying to become an educated consumer and learn how to get your stature lengthening, which I'm not opposed to, but do it safely and end up with the added inches without sacrificing function, you know, or health.
That's excellent. Awesome. And the last real question of the day is, we know Dr. Paley is on the development board. He works closely with NuVasive. Patients have asked me left and right to get your take on the new weight bearing nail. As much as you can say, if you can say anything or maybe hint at it.
Yeah, so NuVasive is responsibly and diligently working on a stride nail replacement, okay, and the new weight-bearing nail. Yeah. And I am involved in that, and I am aware of their progress. Okay. The latest, I did ask them, you know, what kind of schedule do you think at the earliest? And what they've said at the earliest, and you can't hold them to this date, but you know, because remember, even once they have developed the device, you have to go through the FDA again. You got to get it approved, and so on. And then it'll probably be on a limited release to, you know, experts like myself and a handful of others before it's released generally. So the new stride nail, if you want to call it that, the new weight-bearing nail, at the earliest is Q4 2024.
Oh wow!
So okay. we're still 2 years away.
Okay. Wow, that's different than what we've heard. So we're glad that you clarified that for people, because I think, you know, we got their hopes up with other information. So, all right.
Yeah, I think I want to put a plug in for the precise nail, in that. Remember that we put in thousands of them before the stride came out, and we had very good results, you know, with the precise 2.2, and we've never stopped putting them in, you know, and we are continuing to put those in. The final result between those versus stride are no different. Sure, using the stride was, you know, easier because you could walk and you had less weight-bearing restrictions. The final results are no different, not one bit of difference. And in the end, at least I can say this, in my hands, you're going to end up with the same excellent result, whether you had the weight-bearing nail experience or the non-weight, the limited weight-bearing with the precise.
Right.
People want to wait. I respect that. But if they don't want to wait, you're not getting a better result. You're just maybe having an easier period of time during the 4 or 5 months that it takes to lengthen and consolidate the bone, which you would have gotten to be more weight-bearing with the stride than with the precise.
That's a perfect way to put it. Okay. All right. So real quick, Dr. Paley, your final advice to patients, you just said it, safety first, pick your experienced surgeon. But if you can update us, what's new at the Paley Institute? Anything new and going on over there?
Yeah, I was always new. I mean, we've grown to 20 surgeons.
Wow.
And we have every aspect of orthopedic surgery and actually neurosurgery covered. We have 2 neurosurgeons on our staff now, and we also have a couple of pain management specialists who are part of our faculty now. And look, our model is I've recruited an all-star team of what I call my dream team of orthopedics from every aspect of orthopedics, the best of the best, and they bring patients from all over the country, all over the world in their specialties. So whether it's shoulder, elbow, hand, foot, knee, hip, spine, etc. So that's what's new in general. And we keep growing. Our physical therapy department moved to a new building. It's more therapists. We have about 35 physical therapists. So we have huge capacity to support the limb lengthening process. And that's what separates our center from most places, is that we have the infrastructure as part of the treatment. And a lot of places you go and you get your limb lengthening, they send you home. You're taking your life in your hands, your function in your hands. That's why we don't do that. And a patient insists on that, I tell them, go elsewhere. We're not going to do that. So having the infrastructure to support the lengthening is a critical part of a successful limb lengthening center, in my opinion.
Okay. Very cool. And how can you be reached? I actually have all of Dr. Paley's contact information below in the show notes. So if you want to reach out to him or his patient coordinator, Angelique, who's also in the chat, you can do that below. All right, Dr. Paley, do you have, I just want to beg for 10 minutes. These patients have been begging for having you on. If we can do a live Q&A, they would love that. Sure. So, okay, cool. So let me just stop sharing my screen. And Randy, he's already got the first question up. So let me get us back on here. Hold on, let me just minimize this. Here we are. Hello, Victor and Dr. Paley. My question pertains to the ability to fix a slight knock-knee deformity with limb lengthening. If I undergo cosmetic limb lengthening, can I fix the knock-knees too?
Great question. When we lengthen the femur or the tibia, or both, we do have the ability to change alignment through the same bone break that we're doing. In the tibia, it's easier to change alignment than in the femur, because typically the bone break in the tibia is in the upper end of the tibia, close to the knee, and that's where you can change, bow legs or knock knee. And at our place, in fact, that's one of the options we offer people, is if you have a tibial deformity, and we're doing tibial lengthening, do you want us to correct your bow-legged, which is more common, or knock knee deformity at the same time? So for tibia, that's one thing. For the femur, the breaking the bone is usually higher up in the bone, and therefore you can't change alignment of the knee. Okay, so bow leg or knock knee. You can do it if you do what's called a retrograde lengthening, which is cutting the bone at the bottom and putting the nail in through the knee. Or alternatively, you can do it as a separate bone break either at the same time or at the time of, let's say, rod removal, if it's from the femur. And the latter is my preference. So I'll typically do it in conjunction with the removal of the rods when it's knock-kneed and it's a deformity of the femur. That's my preferred way.
Okay, very cool. All right, Randy, next up. Another question, would a person with tendinitis be recommended for tibial lengthening? This person would also be generally pretty flexible, just have some right ligament joint issues. Or tendon issues, I guess he means.
Yeah, look, if you've got some orthopedic issues, such as tendinitis, then, and the most common two tendinitises in the lower leg are either posterior tibial tendinitis or Achilles. It is better to kind of resolve that stuff before you lengthen, because you'll only irritate it more with the limb lengthening process. So if it's related to some kind of deformity, let's say flat foot, so on, you may have to address that before you start with the lengthening.
Okay, very cool. Now, I just realized I actually forgot to ask Dr. Paley on the last slide about picking a good surgeon, because this is literally the most experienced limb lengthening surgeon in the world right here. You guys got to know. And I wanted him to kind of give his take, his perspective, how to do that. And then we're going to go back to answering some live Q&A questions. So don't worry, he's going to answer your questions in just a minute. But this is super important because we just went through a whole 2 hours of complications. So if you want to kind of figure out how to best avoid that, Dr. Paley is going to tell you how to pick a good surgeon here. So Dr. Paley, you're up.
Talk about putting me on the spot, Victor. No, I'll tell you why, because I'm not doing this to be self-serving. I really am not. I am more concerned about what I'm seeing happening a lot of times, where patients are being harmed. Okay, and I don't think they're being intentionally harmed, but they're being harmed due to inexperience of the surgeons performing this, or ignorance, or so on. And so here's the problem with limb lengthening. So in order to pick a good surgeon, you have to understand some aspects of this entire thing that you're getting into. The first thing is that orthopedic surgeons in general are trained very different than plastic surgeons. Plastic surgeons are trained to deal with cosmetic problems. Okay. Orthopedic surgeons, what we're trained to do is deal with pain and disability. Okay. We're really not trained to treat cosmetic issues. Yes, we are conscious that when we're done, things should look nice. We're not oblivious to that, but the motivation and so on, we're not used to treating what we call body image issues, which is what most plastic surgeons are trained to do. Mm-hmm. The second thing is most orthopedic surgeons do their work based on an insurance reimbursement structure and not doing it based on cash business. Yeah. Now, cash business is very attractive to anybody, because the insurance reimbursement gets more and more restricted, more and more rules, and keeps going down. But cash business is very attractive, very lucrative. Unfortunately, it's also very corrupting. And to anybody, I'm not going to lie. There's no question, if you can get paid more to do something, you may consider it. That may be your consideration for why you're doing it. The first 22 years that I did stature lengthening, so I've been doing stature lengthening for a long time. Yeah. I was a fully employed physician, and I didn't receive any incentive or bonus or anything based on how much money I brought into the practice. So it didn't matter if I did a Stature full pay patient or an insurance patient or a Medicaid patient or anything else. So I mostly worked on Stature lengthening in order to really figure out how to do this safely, because I felt this was something important to do. And there were so many potential pitfalls. Now, I am in private practice now, and definitely I do profit from, from sometimes I get profit more from a cash paying patient than an insurance, reimbursed patient. So I'm not going to lie. But I think I did it for so many years with that other approach and motivation that this really, as much as anyone can say it doesn't bias or corrupt me, it really doesn't, because of how I did this for so many years. But there's no question a lot more surgeons have gone into this for mercenary reasons. Mercenary meaning they're going to get paid, and they're going to get paid handsomely, and it's very attractive. So I'm laying that down as the groundwork and the background for you to understand. And nobody ever criticizes a plastic surgeon for taking cash and for being paid that way. It's part of the landscape. We're not used to that. It's not how we were brought up or trained or anything else. We're used to treating, like I said, pain and disability and being reimbursed by third parties, not by individuals. So that's the background. So a lot of surgeons have gone into this because it pays.
Yeah.
Okay. Now, that should not be, we got to be careful of that. We got to make sure that they have the credentials, they have the knowledge, they have everything else that goes with it. I have nothing against people being paid and making as much money as they can, but I want to make sure that they're delivering the services that the consumer thinks they're buying. Mm-hmm. Okay. So if I was shopping around as a lay person, how do I get the safest and best, because there's now a lot of options. It used to be only me, and I did it responsibly, I think, so, but now there's a lot of people, and I'm not going to mention names, and I'm not going to be the Better Business. There is no Better Business Bureau for Limb Lengthening. I'm not going to say this person's good. I do know, and I'm never going to tell you. Okay, because it's unethical, it's unprofessional, and so on. What are the qualities? First of all, you got to look, and this requires a lot of research. You got to look at their training as an orthopedic surgeon. Of course, you want them in the United States. You want them board certified. Outside the United States, there is no such thing. But that means very little. Okay, other than that they've passed their exams and so on. You want to understand how long they've been doing limb lengthening. Okay, so these are the questions. How long you've been doing limb lengthening? Okay, who do you train with? Limb lengthening, there are special training. If you trained with me, you've been trained by one of the best. There's other people in the country who are in that list of the best, and if you train with one of them, that's a really positive thing. Of the limb lengthenings you do, what percent are cosmetic? Right. And if it's 100%, okay, I would stay really clear. Okay, I'm telling you, you want to know where you learn limb lengthening? You don't learn it from Stature patients. Right. Okay. Their Stature lengthening is not as difficult as lengthening, let's say, a congenital or post-traumatic or other causes. So if you've done a lot of limb lengthening for non-Stature patients, you learn a lot, and you learn decision making. You learn skills. You learn how to get out of trouble, because they're often more difficult cases. There may be a crooked bone. Stature cases are mostly straight bones, big bones in adults. Okay, so if you've done a wide variety, it's better than if all you do is stature. You also want to know how many cases of limb lengthening have you done? Okay, I've done 25,000 limb lengthening surgeries. I'm not putting that out there as a, everyone needs to do, nobody, I'm not sure anybody ever is going to do that many in a career ever again. So that, you can do a fraction of that and you're more than experienced. But, but definitely the more you do, it's like anything. The more you do, the more better your muscle memory of knowing the surgery, the better decision making you make doing this. How many years you've been doing it, and so on. There's a famous African saying: when an old man dies, a library burns down. What it's saying is that there is sage advice and sage knowledge that comes from experience. And so how many cases have you done? How many of them are limb length discrepancy? How many are stature lengthenings? And what's enough? I mean, I can tell you that, honestly, until you've done, 50 to 100 stature lengthenings, you haven't seen a lot of the complications. I mean, take fat embolism. It occurs in 4%, 4 out of 100. So if you've done 10, you may have 0. Okay. If you've done 50, okay, you might have 2. Done 100, you've seen 4. If you've done hundreds, you really know how to treat some of these rare complications. So listen, as a patient, if you get a complication, for me, it might be 1%, 1 in 100. For you, it's 100%.
Yeah.
And people forget that. Yeah. It's like the famous joke. Doctor, how many of these, what's the risk of this thing? Oh, it's only 1 in 1,000. Okay. How many of these procedures have you done? 999. And he's never had the complication. So the patient runs away because they feel they're going to be the 1 in 1,000. But the whole point is, if it's you, it's 100%. Okay, no matter how rare it is for me. So you want to make sure that your doctor knows how to manage every situation. I can tell you. So you don't see how good a surgeon is in any aspect until you actually get a complication.
Yeah.
And that's when you need the experienced surgeon, okay, to know how to deal with it. Now, even more so, one of the reasons you may not be getting the complication is because they're so experienced, they know how to prevent things. So the more experienced you are. So bottom line is all these things, and by the way, no insult or put down to young surgeons and less experienced. Everybody starts, with no experience. Okay, everybody starts with a learning curve. Look, I have with me 3 younger surgeons that work directly in my practice: Dr. Robbins, Dr. Miller, and Dr. Shannon. Okay, actually, they're young, less experienced surgeons than myself. They're probably more experienced than almost every limb lengthening surgeon in the country at this point. Even in a year with me, you see some, you do 800 limb lengthening cases, of which many are at least 100 are stature. So, but the point is, you're asking me for yourself, I'm not saying these are bad surgeons and so on, but if you're shopping around and you're going to have to decide who you're going to go to. In every aspect of surgery, the more experience, the more higher up on the learning curve your surgeon is, the better, And so, unfortunately, the guiding, what the single biggest decision-making factor for most people is cost.
Yeah.
And cost is the worst. I understand that's practical. You know, if one surgeon costs 70,000, the other costs 100,000. By the way, that don't get misled. That's not what the surgeon earns. You know, just the implants, these precise nails are almost 20,000 a piece. So whatever the cost, the rods themselves are the biggest single cost of the fee. Then there's the hospital fees, which includes anesthesia and so on. You know, and then we provide physical therapy. I mean, physical therapy is very expensive daily, and we provide 12 weeks of it. It's significantly expensive. You know, and office visits, X-rays. You know, the list goes on. So the surgeon's fee, actually, believe it or not, is the smallest part of all this. But you need to kind of look at what support do you get for your limb lengthening. So if you're just paying for the surgery and you're being sent home, personally, I think that's in itself dangerous. I don't do that. And I don't think that's the way to do stature lengthening, at least not at this point. And I think all patients should stay locally. And the fact, some of you in the audience say, I got away with it. You're right. That's exactly it. You got away with it because you have no idea what bullets you dodged. Okay. So, you know, for me, it's not the safest way to do it. I will only do it the safest way. So you got to inquire with your limb lengthening center. What's their protocol? How do they do it? Do they offer physical therapy? For me, there's a very specialized type of therapy that should be part of it. How often does the doctor see you? Okay. When you're lengthening 1 millimeter a day, or even 3/4, you should be seen every 2 weeks. That's my protocol. If I'm there or one of my assistants is there, every 2 weeks, we check you, we do an X-ray, we examine you, and so on. You know, so look at the protocol. See if they've published anything. You know, for us, we've published our protocol. We've published peer review results of our stature lengthening. You know, that's very impressive. If your doctor has published, then you can go over. I see you published you had, you know, 3 deep vein thromboses, and what's my risk of this? And I see that you had 3 non-unions, and how did you treat them? And you know what? Now that you know the list of risks, ask the doctor, have you ever had this? Have you ever had this? Have you ever had this? And how have you treated it?
Great.
Okay. And they say if they never had any of these things, you probably should run away because you know what? I've had every complication in the book. Okay. I joke around that I'm the most experienced limb lengthening surgeon in the world because I've had more complications than any other surgeon in the world. I've experienced everything. Okay. It doesn't mean I have them frequently. It means I do such a large number. But when you do such a large number of something, you see everything that can happen. And every now and then, I'm still surprised by something new. It shows you that, you know, no matter how experienced you are, you haven't seen everything. Okay. So, and we've written up everything. We've published. We've put it all out there. The more of those items that I'm mentioning on the checklist, the more comfortable you should be with your limb lengthening surgeon. Unfortunately, the list of people that I would go to in the United States that meet my criteria is extremely short. There's a lot more people offering the service than I would consider going. Just because they advertise, just because GQ chooses to do a story on them, that's not an endorsement. It's got nothing to do with any of that. It may mean you have a very good publicist. It may mean that, you know, you're really good on camera. It may mean, you know, or it may mean you're the best. It could be both of those. It could be any of those. Listen, I had an article in GQ on in the older methods of limb lengthening. Did that prove anything? No, it proved nothing. That is not where you want to see if they're how good they are. Are they published in a peer-reviewed journal on this? What What are their protocols? Are they meeting all these things? Get a sense of how much experience. These are all the way you decide about something which endangers your own safety. So to me, that's, shop around, visit with different people. I know that cost is a major factor, but if you make your decision just in the end based on cost, you may get what you pay for. It's not an endorsement.
Well said by the greatest limb lengthening surgeon of all time, Dr. Paley. Well, we're going to go back into a few questions here. I know that some patients, you have fans out there. So, so Randy, yeah, go ahead and pop them back on here. We'll do, how much time do you have, Dr. Paley? I know you're leaving today. You're going out of town. 10 minutes?
Yeah, my wife's waiting for me to go do something with her, but I'll answer a few questions.
Okay. All right. Let's do a few minutes here. Adam Alex is saying, I'm an ectomorph. Whenever I did bodybuilding using heavy weights, I didn't gain larger muscles. Does this indicate that I'll have a rough time as I approach maximum lengthening? I'm 5'8".
Nope.
No, there you go.
Your body type does not, the implants are strong enough to lengthen people with some of the biggest muscles. And, that's really not an issue, whether you're an endomorph, an ectomorph, or any of this stuff.
Okay. All right. Very cool. All right. Average dude. Dr. Paley, what do you think about retrograde femur lengthening to maintain perfect alignment?
So first of all, I don't think it necessarily maintains perfect alignment. And what you're referring to is that you do some type of procedure to correct varus or valgus, or to mitigate this issue that I talked about before of lengthening along the anatomic axis. Too often, I see a secondary deformity created by that.
Yeah.
And it's not worth it. The other thing is, the closer you are to the knee when you lengthen, the less total length you can get, because you start getting stiffness of the knee. And then drilling a hole in the knee, because you are going right through the cartilage of the knee, is not necessarily the best thing, not for your kneecap and not for the knee itself. We use this technique, don't get me wrong, in all kinds of situations, especially when we do have deformities of the distal femur. But it would not be my preferred choice for an elective cosmetic stature lengthening, unless I was limiting the amount of length and there was let's say a valgus deformity of the lower femur. Although, as I mentioned earlier, even in those cases, I'd rather lengthen proximally and do a realignment distally with a plate instead of a nail through the knee.
Wow, just like that. All right, average dude, you got that.
It's actually a very savvy question, and it really, and the answer to that shows you what a surgeon knows or not, because there's a lot of considerations in answering that question.
Right. Okay.
These are decision-making points.
Yeah, it shows experience right there. All right, Randy. Alexandros, hi, Dr. Paley. Hope you're well. I was diagnosed with hip impingement on both sides, but labral tear on the left hip. Currently undergoing PT and getting some relief. That's the first part of his question. And then he says, but I'm afraid I'll have to do arthroscopic surgery to help fix my hip. If this happens, will I still be a good candidate for limb lengthening? What would someone with my condition have to be careful for limb lengthening?
Yeah, so you're still a good candidate for limb lengthening. The hip impingement problem is not going to go away. It won't necessarily be made worse by the lengthening. If you're getting labral tears, it's often a structural problem, in terms of what's called the version of the acetabulum, the socket of the hip, the way it's shaped, or a bump on the neck of the femur. None of that's going to be made worse by lengthening, nor better. I think you have to deal with that problem independently.
Okay. Very cool. All right, let's take 3 more questions. Kurdayeti is saying, is it right to do a quadrilateral lengthening at the same time? Oh, so lengthening the femurs and the tibia.
Yeah. I would love to, and I have done it. I've pushed the envelope, and My first one that I did was actually, he was a cardiac anesthesiologist. So, I mean, this guy knew more about fat embolism and all this stuff than I do, and was willing to take the risk. And we did all kinds of things to monitor him. We put a special type of stethoscope inside his esophagus so we could listen to the heart while we were reaming, and you can actually hear the fat traveling through the heart. Okay, it's really scary. Can I tell you, at the end of that operation, I was a nervous wreck because the entire time of the operation, I could hear the fat going through the heart, and I'm thinking I'm killing this guy. He never even dropped his oxygenation or whatever. I never want to hear that stuff anymore. It's it's very nerve-wracking. Got away with it, and that's literally what happened. He was so healthy and so fit, and he was. And got away with it. He was 52. We did do the quadrilateral at one time. I then did another boy, and he had horrible fat embolism syndrome. And I've never done it again. You know what? It's not worth my coronary artery spasm that I get as I'm doing this thing, which I'm getting, we're getting into trouble in 4% of bilateral, 2 segments. To do 4 segments, you're really asking for trouble. So again, I just didn't feel it fit with, it just wasn't safe enough. The cost savings is probably about $20,000 because you have less hospital fees. It just wasn't worth it. And the risk to the patient is that, is worth dying for $20,000. I'm sorry. I'm not going to be part of that. So I don't do that anymore.
Okay. Very cool. All right. We take a couple more questions here and we'll be all good. Thomas Ha, what does Dr. Paley think about tibia lengthening with the Ilizarov and something frame in 2022? Okay. Yeah. You know about that. And he's saying it was patented in 1977 by the Soviet surgeon. Yeah. So I'll let you take that one.
Dr. Kalnberzs was a friend of mine. I visited him in Riga, Latvia. Amazing host. Actually spent some time with him and his son, and both orthopedic surgeons. So I know them very well. It's just another Ilizarov type external fixator. So it doesn't matter. The real question should be, what do I think about lengthening with external fixation in 2022 versus using implantable? So to me, look, for a cosmetic procedure, it's the least cosmetic thing in the world to put an external fixator on your leg. Plus, every pin and wire causes a scar. So now you're creating scars, and patients who are having stature lengthening are very scar conscious. So to me, it is a step backwards. I did this all through the late 80s and through the 90s. And then we switched to, implantable and we still use it to some extent in dwarfism. But I think for cosmetic stature lengthening, I wouldn't do it. The only reason people are doing it is that many countries do not have, for China, for example, does not have, the implantable lengthening nail. And the implantable lengthening nail is expensive, while fixators you can reuse them because they're outside the body. You can re-sterilize them, reuse them. You can't reuse these nails. Okay. So the cost is greatly reduced. Remember that $40,000 cost just for the implant, greatly reduced by using the X-Fix. It's much more painful. It's much, there's a lot more to go through. But I personally have done hundreds like that in the old days when we had nothing else. Yeah. Would I do that? Would I do that now? No. Would I, as a patient, want that done this way when this is an alternative? No. But if you then say, if I can't afford to do it with the implantable, and I have a really good surgeon who's experienced with an external fixator, is it a reasonable thing to do? Sure. I mean, we did do that. And then the next step up, what about lengthening over nail, where you put a rod in and you lengthen it over the rod and get the fixator off earlier because you're locking the nail and taking the fixator off? That's a technique I developed in 1990 and published in 97. Yeah, I mean, that's even a better than just doing the fixator and being in the fixator in for much longer. And I guess if you have very limited resources, it's a reasonable thing to do. Not my choice anymore.
Okay.
And I won't do it anymore. And basically, people have come to me, said, well, wouldn't it be cheaper if I did it? It would, but I'm not doing it. I will only offer the implantable limb lengthening for Stature. And we use external for all kinds of things still. So they haven't disappeared, but I won't do it for cosmetic lengthening.
For cosmetic purposes. Okay. All right. Last two questions here. Parth, he always has good questions. Dr. Paley, any plan to bring the Paley Institution to the West Coast? It's nice and sunny in California too.
Yeah, I have actually looked to open a place out there. California actually, regulatory wise, has all kinds of things that make it unattractive. I've looked actually at Arizona, which is a little bit more attractive. And at the present time, I haven't done it, but it has been a consideration. I've opened up around the world. I have a Paley European Institute in Warsaw, Poland. We do a lot of work there, including Stature. And where I'm going tonight, I'm flying to Abu Dhabi in United Arab Emirates, and we're opening up there. And we're, you know, and you know, for example, a lot of our Chinese patients, you know, right now we used to treat a lot of them here, and Angelique, who's on the call, actually is fluent in Mandarin and interprets for us and provides those services. You can see her email going across the banner, Keller@paley.org. That's our stature lengthening coordinator if you want to email her. Very responsive. But so we're set up to treat Chinese patients here, but because of the, you know, all the problems with, since the trade war with China, getting visas and so on, it's become a challenge. So we will be available. You can email us. We will be available to do this either in Europe. It is cheaper in those places, mostly from the hospital cost perspective. Hospital costs are a little lower. And we're also next year going to open up in South America, probably in Medellin, Colombia. So we're going to have South America, Asia, and Europe set up and it'll be Paley Institute surgeons. We are flying out there. So it's not, you're not getting some local surgeon. The local surgeons are on a team are excellent. You know, there are boots on the ground and they look after the patients after we leave. So you're not, and these are all people who trained with us, but the actual surgery is being done by Paley Institute surgeons.
Very cool. Very cool. They're expanding, guys. You hear that? Paley's going worldwide. All right, let's take this last question. And if you guys have other questions that you want, like Dr. Paley said, you can email Angelique. Her email is below the video. All right, the real Ash. Dr. Paley, have you seen the rate of complications increase as the age of the patient? So as the patient's age goes up.
This is a fantastic question. I appreciate that question because I didn't cover that. I kind of touched on it a little bit. So we've done stature lengthening for cosmetic reasons. We start at skeletal maturity, which in girls can be around as early as age 14, boys around age 16. And so we start in the mid-teens. We've gone, I think our oldest is 67. Okay. I just turned down a 72-year-old, which is not because of age discrimination, but too many medical issues, osteoporosis and so on. But so again, safety, it wasn't safe in our opinion. So how do these older, and remember, older is only anyone who's older than you. So now they're not older anymore to me. But you know, how do these relatively older patients do with limb lengthening? And interestingly, they don't have a higher complication rate. And we don't lengthen as fast. So for someone in their 50s and 60s, I will lengthen at 3/4 millimeter a day. And the cost goes up a little bit just because they have more office visits and a little bit more physical therapy. Not that much more, but it you know, and we tell them in advance, you know, it's not going to be 12 weeks to do an 8-centimeter lengthening. You can still get 8 centimeters in the femurs, but it's going to be more like 16 weeks. okay, because we're going to go 3/4 millimeter a day. And so instead of getting 1.4 centimeters every 2 weeks, you're getting 1 centimeter every 2 weeks.
Yeah.
And, so we've done it very safely, very carefully. Have they gotten like tighter in their muscles earlier? Not necessarily. But they, I got to tell you, the older individuals work harder. I do have one funny story, but it was a cardiac surgeon from Canada who did the limb lengthening with me, and I did this is still in the ISKD days, so not the most reliable device, but we did 5 centimeters, and I said, you got to stop, and he refused to stop. He wanted to go 1 more centimeter, and that's when he got his peroneal nerve problem in the last centimeter. And I told him to stop because he was getting tight. So when the doctor tells you to stop, okay, stop. Okay, this what I call lengthening greed. Okay, being greedy at anything, is associated with consequences, and lengthening greed is associated with potential health risks, and potential disaster. So if the doctor says stop, stop. I don't want to hear this, but I paid for 8 centimeters. No, you didn't actually. So I want to make it clear when someone comes to me, I tell them they can get up to 8 centimeters. It doesn't mean I guarantee 8 centimeters. They didn't pay for 8 centimeters. They paid for the potential to go up to 8 centimeters. Okay, it's the same surgery to do 8 as it is to do 5. Okay, so you paid for us to do this safely, and we're going to tell you when it's no longer safe. And but age, I mean, do people heal faster? I think actually teenagers definitely heal faster. Up to about age 30, you heal faster. 30-year-old and a 60-year-old heal the same rate.
Yeah. Wow, that's incredible. Very cool. Well, everybody, that is it for the live Q&A. We don't want to hold Dr. Paley up. His wife is calling him. He has to go somewhere. But we'll have him back. We'll have him back whenever he has time to come on to do some more live Q&As. But Dr. Paley, we want to thank you for coming on. So everybody in the chat, show your love to Dr. Paley. Say thank you. We love you, whatever. We want to thank you coming on to talk about all these complications about limb lengthening. You're the most experienced in the world. The Paley Institute, if you guys want to reach out to Angelique, again, all the contact information for the Paley Institute is below. So you can reach out, ask questions. We also have his website for stature lengthening, limblengthening.org. So if you visit that, you can find out more information about what they offer there. And yeah, so Dr. Paley, I want to thank you for coming on. Randy, I want to thank you for helping out for the questions. I want to thank everybody worldwide for watching live today for 3 hours. And this has been the biggest live stream we've had since the first one with Dr. Robbins. So yeah, let's give it up for Dr. Dror Paley, everybody. Yeah, exactly.
How many people do we have on, Victor?
Right now, I think we topped off at like 60 per. It's been consistently 60 through. So probably 300, 400 people have seen us so far, and you'll get into the thousands by the end of the week. So I'll make sure to send this to you guys so you can have it for your social media as well. So awesome, Dr. Paley. Thank you so much.
Victor, I want to put a shout out to you. You have been an incredible advocate for the group of people who are looking for solutions to height, and you've actually been very credible and very impartial, and you've obviously gone through this yourself and know what's involved, and I think everyone owes you a debt of gratitude in that respect. And I'm going to pay homage to you by adding one last comment, and that is, and this is something that maybe only I can say, but people ask all the time, are there late consequences, like 20, 30 years later? What happens? I'm sure you want to know that. You've been through this. Should you expect to get hip arthritis, knee arthritis, or something in the future? And here's the good news. Honestly, if you get through this, when you finish and you recover, you're not going to see any deterioration. We're not seeing. I have patients 30 years later, and their joints look as healthy as they did at the end of the lengthening. So the reassuring thing is we can do this safely. We can get you back to absolute normal. You should be able to expect that and nothing less. And I did this show to make sure that you know what to expect, know how to look for it, and protect yourself so you can live a long and healthy life and enjoy life. So I thank everyone.
Yep.
Be well.
Awesome. Thank you so much, Dr. Paley. All right, guys, this is Victor from Cyborg for Life signing out. We'll see you guys next time. Bye.